Yes, we are live on YouTube.
Okay. We'll start. Okay. Good evening, everyone.
Ganesh?
Yes, sir.
I'm sorry for interrupting.
Yes, sir.
Shall I ask Dr. Parameswara sir to introduce both the speakers, or?
Parameswara sir will introduce first speaker and you can introduce second speaker, sir.
Yeah, fine.
Yeah,
fine.
that's
okay,
right.
fine.
I will introduce Rajesh Mane. You can introduce the second speaker. Yes.
Yeah. Anyway, their first slide contains the brief introduction. We'll not have a very formal, elaborate introduction.
Yeah. Okay.
Good evening, everyone, and welcome to the 6th monthly program of Indian Society of Anesthesiologists Karnataka State Chapter. Today, we have two distinguished speakers. Dr. Rajesh Mane will be speaking on one lung ventilation, and Dr. Rajesh Latkar will be speaking on regional anesthesia for freelancers. So it will be an interesting mix for both postgraduates and practitioners. And I welcome both the speakers for today's session. We also have two senior members of ISA as chairpersons, Dr. G. Parameswara, past GC member of ISA National and senior consultant at Manipal Hospital, Bangalore as the moderator, and also Dr. Venugopal Nori, President ISA Andhra Pradesh and senior consultant as the second moderator for today's session. Welcome you both, sir, Dr. Parameswara sir and Venugopal sir. We also have our office bearers of ISA from Karnataka, from different city branches and outside Karnataka as well. Welcome you all, sir. And I also welcome the postgraduates joined in, senior anesthesiologists of Karnataka, the practitioners from various parts of Karnataka for this session. With this, and also I will request, yeah, we can do that later. Maybe we have just a brief announcement regarding ISA Karnataka Virtucon, which will be held in December 12th and 13th online. The program, I think we can share that at the end. I'll do that. With this, I request our President of ISA Karnataka, Dr. Vijayanand sir, to please make the opening remarks. Vijayanand sir?
Yes. Silpa has muted me. Okay, sorry.
You are audible, sir. Please go ahead.
Good evening, Vice President, Secretary, and Office Bearers of the Karnataka ISA. I welcome the speakers, Dr. Rajesh Mane, Professor Head of the Department of Anesthesia, KLE, Belgaum, and Rajesh Latkar, as a senior practitioner in Belgaum. I welcome the two distinguished chairpersons of the today, Dr. Parameswar, who needs no introduction. He is a Pitama of ISA, Bangalore, and is a senior consultant professor at Manipal Hospital, Bangalore. I welcome the President of Andhra Pradesh, Venugopal Nori, for this academic activity, which we are doing monthly. I welcome Dr. Balabaskar, Immediate Past President of ISA National, and Dr. Gurudat, Academic Advisor to KISA. I also welcome all the senior anesthesiologists and postgraduate for the 6th monthly meeting of academic activity. I hand over to the Ganesh to proceed further. Thank you. Thank you.
Thank you, sir. I invite Balabaskar sir to make the opening remarks, sir.
Yeah, thank you, Shri Ganesh. Let me be brief. I welcome the esteemed speakers, Dr. Rajesh Mane and Dr. Latkar, and of course, Param sir and Venugopal, our senior GC member and president of ISA Andhra Pradesh State, respectively, and Gurudat sir, the academic advisor for ISA Karnataka, and the host state, Dr. Vijayanand, President, and Dr. Ganesh, the Secretary. Thank you very much for involving me in this activity, and I wish all the best for today's program. Thank you very much.
Thank you, sir. I know you have other commitment and you will be busy. I request Gurudat sir to also lead this academic program for today's session. Gurudat sir, please. Thank you, sir. You want to say one or two words before we begin, sir? Gurudat sir?
Can you hear me? I was
Yes,
muted.
sir. You are audible. You are audible and visible, sir. Please go ahead.
Okay, okay. Today we have very good two sessions actually. You know, one of the thing is lung isolation techniques by Rajesh Mane, and another thing is regional anesthesia techniques. How a private practitioner can make the anesthesia very successful. So both speakers are probably they have prepared very well, and I think all the people, especially the postgraduates and also the consultants, will have a feast of these two lectures. So over to the speakers.
Yeah, before that, I think I invite, thank you, sir. I invite Param sir to kindly introduce the first speaker, Dr. Rajesh Mane. Mane sir, you can share your presentation and the first slide.
Yeah. Good evening to all of you in this Karnataka webinars. The first speaker for this one is Dr. Rajesh Mane, who is well known, and he is right now head of the department of JNMC Belgaum. I don't want to, he is a very well known speaker and has given a lot of lectures and all in various conferences. Now, he will be talking about lung isolation techniques and management of one lung ventilation, which is not only important as far as the anesthetic management is concerned, but for postgraduates, it is equally important as the questions in the written examination, as well as in the practicals when one of the lung cases comes up. So I request Rajesh Mane to proceed with this lecture. Thank you very much.
Thank you, sir. Before Mane sir proceeds, one announcement for postgraduates. There will be quiz questions, and as is our format of our monthly program, the fastest correct answer will get certificate of appreciation from ISAKA Karnataka for each of the questions. With this, over to Mane sir, please.
Thank you. Thank you, Param sir, for the introduction. Ganesh, you can hear me now?
Yes, sir. You are visible and audible, sir.
Okay. Greetings
You
from
are audible. Please go ahead.
Greetings from ISA Belgaum City and Department of Anesthesia, Jain Medical College, Belgaum. I'd like to thank the ISA Karnataka officials, Dr. Vijay Anand, Dr. Shivkumar, and Dr. Sri Ganesh, and also Dr. Bal Bhaskar and Dr. Gurudat for giving ISA Belgaum City moment for conducting this monthly academic program of ISA. Today, my talk is on lung isolation technique and management of one lung ventilation. As Dr. Param sir said aptly, it is one of the most important topics for the postgraduate students, not only at the theoretical point of view, but practically when they face cases for management of one lung ventilation. As you know, one lung ventilation is indicated for surgeries on the esophagus, on the mediastinum, great vessels, and the lung. The primary problem with one lung ventilation is the management of hypoxemia which occurs due to one lung ventilation, which can be quite catastrophic in a compromised patient. Thus, it provides a significant challenge to the anesthesiologist and the surgeon as well. This lecture of mine will be covered under the following headings: history, indications, physiology during one lung ventilation, lung isolation techniques, and the perioperative care, which include the prediction, the prevention, and management of hypoxemia during one lung ventilation. Before I go to the history, at this juncture, I'd like to commend all the ISA, all the anesthesiologists of ISA Karnataka State and the national for their commendable job in the treatment of COVID patients. Okay, I forgot to mention that in the beginning. Coming to history, well, the idea of isolated lung ventilation goes back as early as 1841, with its origin from bronchospirometry studies. And later on, it has developed vastly and developed since the last century. It was initially the physiologist who tried to study gas exchange in the lungs of dogs, which led to a scientist named Head in 1899 to devise a variant for the double lung tube. Many years later, building on this idea, it was Galen Waters who created a DLT for use in humans. Later on, it was Rosenstein who added another cuff to the DLT and named it the bronchial cuff. Then our own Sir Ivan Magel made the first right and left DLTs. He was the one who devised the endobronchial blockers as well. Later on, with so many modifications, testing, identifying the problems associated with DLTs, many more modifications were designed. For example, the Carlin's DLT with the carinal hook. But later on, it was in the year 1960, Robert Shaw, who combined the best features of all the different DLTs and came out with the right and the left-sided DLTs, which we use now commonly. Well, as you all know, there are some indications for the introduction of one lung ventilation, one lung anesthesia. They can be classified as surgical and non-surgical indications. The most common surgical indications are related to lung, which can be pneumonectomy, lobectomy, VAT surgery, and decortication. There are some cardiac surgery related procedures which require one lung, like minimal invasive cardiac surgery, and of course surgery related to esophagus, mostly the carcinoma esophagus surgeries, and sometimes the anterior approach to thoracic spine for spine surgeries. This, apart from surgical indications, there are some specific non-surgical indications as well, which require isolation of each of the lungs so that you prevent contamination of the healthy lung. For example, any infection, unilateral infection or massive hemorrhage on one side, you have to prevent this contamination of the healthy lung. Similarly, when there's a bronchopleural fistula or unilateral bullae, there is, because of a decreased resistance, you have to control ventilation for each lung. Similarly, when you want to perform a unilateral lavage for each lung, you need to have a one lung tube. This can be classified, as I told you, into absolute and relative contraindications. These are the absolute indications for one lung ventilation, which I had mentioned before in the non-surgical indications, like isolation of the lung, control of ventilation in case of bronchopleural fistula, major bronchial or lung trauma, unilateral lavage, and video-assisted thoracic surgery are some of the common absolute indications for one lung ventilation. The relative indications, depending upon the priority of the surgical exposure, they can be classified as high and low. The high priority surgical exposure indications are surgeries for thoracic aortic aneurysm, pneumonectomies, lung volume reduction, and upper lung lobectomy. The low priority surgical exposures are esophageal surgery, the mid and lower lung lobectomies, reduction in mediastinal mass surgeries, and bilateral sympathectomies. Well, before we go into the lung isolation techniques and management of one lung ventilation, let us understand the physiology which happens during one lung ventilation. Normally during two lung ventilation, perfusion and ventilation are well matched, because what happens, the perfusion of the dependent lung depends upon the gravity. So the dependent lung gets well perfused. Similarly, ventilation of the dependent lung is well maintained because of the gravitational effect of the compliance. So hence, the perfusion and ventilation are well matched, and there's no cause for any hypoxemia. But what happens during one lung ventilation? During one lung ventilation, ventilation to one lung, as you know, is completely cut off. Actually, theoretically speaking, this should result in a 50% shunting through the lung. But this does not happen. The amount of shunt is just 20 to 30%. Why so? The causes for this reduction in the shunt fractions are so many factors. The most of the common factors are surgical manipulation, lateral position, and on hypoxic pulmonary vasoconstriction. So what happens during surgical manipulation? When the surgeon is manipulating on the non-dependent operated lung, he obstructs the blood flow. When he obstructs the blood flow, he diverts the blood to the well-ventilated dependent lung. Similarly, lateral position, as I mentioned before, due to the gravitational force, blood is more the lower lung or the dependent lung is well perfused. Then the last one is hypoxic pulmonary vasoconstriction, which occurs, which also is known as Euler-Lizarhand mechanism. What happens here? It is nothing but the physiological phenomena in which the small pulmonary arteries constrict in the presence of alveolar hypoxia. So whenever the PO2 in the alveoli drops less than 100, the pulmonary arteries constrict. These small pulmonary arteries, when they constrict, they divert the blood flow from the poorly ventilated lung regions to well-ventilated lung regions in the dependent area, thus helping to bring about ventilation perfusion matching. So this hypoxic pulmonary vasoconstriction is a very protective phenomena which prevents a major shunt occurring and decreases the shunt fraction. Now let us know what aggravates and what potential, how HPV is potentiated or decreased by which conditions. Well, on the left side, the conditions which can increase HPV and which can be more protective are respiratory metabolic acidosis, mild decrease in mixed oxygen saturation, hypothermia, hypercapnia. At the same time, it can be decreased by hypocapnia, hypothermia, any increase in left atrial pressure, and hemodilution. One thing which has to be noticed here is whenever you give 1 mic of inhalation anesthetic agents, there is no evidence to say that it affects the HPV as it is known, because the other system, the action of these inhalation agents on other systems masks the effects of these agents on the pulmonary vasculature. Now coming to techniques of lung isolation, as you know, these are 3 common techniques which are used into day-to-day practice. The most common being the double lung tubes or double lumen tubes. Next is the single lung bronchial tubes and the endobronchial blockers. So before we go into this lung isolation techniques, let us know about the anatomical considerations which are quite important when you go ahead with one lung ventilation. As you know, the trachea is divided into right and left bronchus. The right main bronchus is shorter, straighter, and has a larger diameter than the left. It takes off an angle of 25 degrees from the trachea, and the upper lobe opening is quite close to the origin of right main stem bronchus or quite near to the carina. While as in the left bronchus is longer and takes off at an angle of 45 degrees. Thus, it is easier to do a right main stem bronchus intubation. At the same time, it is not difficult to obstruct, not to obstruct the right upper lobe opening in doing so. This is quite important thing which all the postgraduates should be knowing of. Coming to endobronchial blockers, the indications of DLT apply here as well, except when independent lung ventilation is required. It's basically used in patients in whom DLT is not possible and it is not advisable. For example, in difficult airway, when need for continuous postoperative ventilation is required, in a tracheostomized patient, whenever there's subglottic stenosis or thick and excessive secretions are present. Basically, they're indicated in critically ill patients who already have a ET2 in place, patients on anticoagulant medications because it causes less trauma as compared to a DLT tube, and whenever there's a need to block only one segment of the lung, this endobronchial blockers are more beneficial, and also when they require a sequential blockade of each lung. The most commonest is the univent bronchial blocking tubes, which is a cuffed silicone tracheal tube. It has a small additional internal lumen along the concave side on the anterior wall of the normal endotracheal tube, and it contains of a stellate with the lumen inside. So whenever you require isolation, you just have to, under the guidance of fiber optic, you introduce into the desired or required bronchus and cause one lung ventilation. And when you don't want it, you just pull it up and you keep it into the tube, endotracheal tube, normal endotracheal tube. This is another common Arnett bronchial blocker, which has a coaxial. The bronchial blocker is coaxially placed inside the endotracheal tube. It has a loop wire at the tip. So whenever isolation is required, it is inserted into the desired bronchial lumen under the guidance of fiber optic. Another common technique as for isolation are the embolectomy catheters, which can be used as for a bronchial as well as segmental blocker. It comes with a stillet. It is possible to place a curvature to guide it to the targeted bronchus. They are high pressure low volume cuff. They come in 2-5 for pediatric and 7 French for adult. It is passed through a tracheal tube or next to it and usually guided by a fiber optic bronchoscope. And as is known, it's cheaper when compared to a DLT or the bronchial blockers. This is the embolectomy catheter. Coming to single lumen bronchial tubes, then are made designed to intubate a mainstem bronchus. Basically, they're used in pediatric patients because, as you know, we don't get DLTs of pediatric size, and especially in emergency situations when there's a massive hemoptysis. It's nothing but a normal cuff tube, which is used for endobronchial intubation. The advantages of these are they're simple and fast to introduce. The main disadvantages are there's a lack of ventilation to the right upper lobe. You may miss ventilating the upper lobe. Then you can neither suction nor apply CPAP to the non-ventilated lung. Sometimes there will be failure to isolate, leading to incomplete collapse of the desired lung. And at the same time, you cannot re-expand the lung till the tube is withdrawn into the trachea. Now coming to the double lumen tubes, which are the most commonest tubes used to achieve lung separation and one lung ventilation. They're nothing but two endotracheal tubes which are bonded together, and it has two lumens. One lumen is long enough to reach the mainstem bronchus, while the other one opens into the trachea. They have two cuffs here, the proximal or the tracheal cuff and the distal or the bronchial. They're color coded as well. The tracheal is white and the distal bronchial is blue, basically to identify the bronchial cuff when you introduce a fiber optic bronchoscope. It has two curvatures, a proximal anterior curvature and the distal curvature to the side to which the tube is designed for. This is the normal double lumen endotracheal tube. It also has two lumens at the proximal end to ventilate separately the two lungs, or also it can be connected by a Y connector and connected to the circuit. So they are right sided as well left sided, depending upon the side it is meant to fit. The right side tubes have a slot to ventilate the right upper bronchus, while others have a cuff shaped such that it allows for the same. Each tube provides a resistance of the same as a 6 to 7 mm internal diameter endotracheal tube. But before you decide on which type of tube you prefer or which tube you want to insert in a patient, we need to know what is the margin of safety. Well, margin of safety is nothing but the length of the tracheobronchial tree between the most distal and the most proximal acceptable position of the bronchial cuff. So compared to the left and the right, the left-sided DLT has a higher margin of safety compared to the right-sided tubes. Let us see how it happens. In the left-sided tube, the uppermost, the proximal acceptable position is when the bronchial cuff is just below the carina. If it is more proximal, it will obstruct the tracheal lumen. Hence, there will be no chance of lung isolation. Similarly, the most acceptable distal position will be just before the takeoff of the upper lobe bronchus. That is why it can be, the margin is quite big here for the left-sided tube. While what happens in the right-sided tube? The accepted position is when the upper lobe ventilation opening is aligned with the upper lobe orifice. Hence, the margin of safety as compared to the left side is considerably lesser. That's why most of us we prefer a left-sided tube for any isolation of the lungs. So there are so many variants of DLTs. I will just go through the names: Garland's, White's, Robert Shaw's, Broncho Cat, Sil Bronco are some of the variants of DLT is used. So this is the Carlin's tube. It is a left-sided tube. It has a carinal hook. Okay, it helps to it can cause trauma as well. The right side variant of this Carlin's tube is called as the wild DLT. This is the most commonly used DLT, Robert Shaw. It's available both in right and left side variants. The bronchial portion is angled at 20 degrees. And as you know, the bronchial cuff has a slotted opening in its lateral aspect for the right upper lobe ventilation, and the cuff extends completely on the medial aspect. The bronchial portion is angled at 40 degrees. So this is a diagram depicting the right and the left DLTs placed in the respective bronchus. You see on the right side, there's a slot which opens exactly opposite the right upper lobe bronchus. This is a sil broncho made of silicone, which is available in 33, 35, 37, 39 French. It is flexible. The bronchial segment here is wire enforced, and it helps in preventing kinking when it is inserted. This is the sil broncho tube. Now coming to the tube choices, which you prefer over which? Well, the right-sided tube is inserted basically for surgery on the left lung, on the left main bronchus. Okay, and also in left pneumonectomy or left lung transplant. The left-sided tubes are basically designed or indicated for almost all surgeries except what is mentioned on the right side. Because it has a higher margin of safety and hence preferred in left lung surgeries also, and also in right pneumonectomies. Well, sizes available. Basically, they are available right from 26 to 41 French. In males, the size usually used are 39 and 41, while in females it is 35 and 37. As for any endotracheal tubes, in DLTs, there is no fixed rule or formula to determine the exact tube to be used, because there is a considerable variation in the bronchial diameter in relation to age, the sex, and the weight and the height of the patients. Hence, it is very difficult to come to an exact formula to determine which size tube has to be inserted. Well, coming to larger and smaller, what happens if you pass a larger tube? What happens if you pass a smaller tube? The larger, it provides less resistance, allows easy suctioning, allows for the free passage of the fiber optic scope. It also reduces the risk of advanced DLT. Many times you just go on inserting the DLT. So once you get a resistance, you need to stop there. But the thing is, it can cause airway trauma, and if it is oversized, the bronchial loop may not fit into the bronchus. Similarly, if it is a smaller size, we may not be able to provide the adequate lung isolation, and it may be too much advanced, too deep, leading to barotrauma. It can get displaced more easily, and suctioning and ventilation can be difficult when you pass or select a smaller size tube. This is a brief or some sort of a formulae in selecting double lumen size tubes for adult patients, males and females, depending upon the height of the patients. Females less than 160, we prefer a 35 French gauge double lumen tube. In females more than 160, it is 37. Similarly, in males, it is 39 and 41 in patient with height of less than 170 and more than 170 respectively. This is a table which depicts the comparative diameters of single and double lumen tubes and the fiber optic size through which you can pass the fiber optic, the size of the fiber optics gauges through which the double lumen tube through which it can be passed. Well, how before you insert these double lumen tubes, what you need to do, or how do you prepare yourself? So first thing what you have to do is deflate both the cuffs. Okay, then you inflate and check for any leak in the cuff, and then deflate them. Apply a water soluble jelly onto the stellate, which is inserted into the bronchial lumen, and make sure that the stellate does not extend beyond the tip of the tube so as to avoid any trauma. At the same time, you have to keep all the connectors ready. Many times the connectors are misplaced, And once you insert the tube, you go on finding for the connectors, and in meanwhile the patient can land up into hypoxemia because you are not able to first identify whether the DLT is in the proper position. So connectors, assemble of connectors is quite important as well. At the same time, you keep all your laryngoscopes, blades, and normal ETT tube in case of emergencies, and a suction always at your side. So once after adequate anesthesia, adequate depth of anesthesia is attained with a relaxant, laryngoscopy is done, a proper laryngoscopy. You see that the laryngoscopy is done and you lift the laryngoscopy properly so that the glottic view is best visualized. Okay, that makes it easier for the DLT to be inserted and placed properly. So once the DLT is advanced with the angled tip, the distal curvature anteriorly, then once the bronchial cuff passes the cords, the tube is then turned 90 degrees, left for the left-sided and right for the right-sided tube. The stellate may be removed at this stage, and then the DLT is passed further down till you feel a resistance. Alternately, the stellate can be left in place and the tube advanced. This results in a more rapid and accurate displacement. There may be a controversy here, some may not agree to this. Books mention that stellate has to be removed once the DLT passes through the vocal cords and before it is turned. Now confirming the position, there are different techniques how you confirm the position. The most common thing which most of us practice is auscultatory. It is easy to do, as you know. The only thing is it does not always detect malposition, because many a times we hear conducted breath sounds from right to left, left to right. And once the drapes are placed and surgery started, it may not be possible to auscultate again. So we just cannot truly say that the tube is confirmatory. The auscultation technique is confirmatory for position of the DLT. Next is the clamping technique used by many or few. Once for the left-sided tubes, okay, you inflate the trachea. There's a bilateral equilateral entry. We inflate both the cuffs. Don't clap. Then still you have the bilateral equilateral entry. Now, when you clamp the tracheal lumen, you are obstructing the tracheal ventilation. So the left-sided tube is into the bronchus. So only the left lung area is left lung is ventilated. So the tube is on the left side. Similarly, when you inflate both the cuffs and you clamp the bronchial lumen, so the left lung gets occluded, the bronchial lumen gets occluded. The ventilation is through the trachea into the right lung only. So this is a clamping technique which is commonly used by many. Similarly, the right side, as I mentioned, on the left side. The another technique is a single connector technique, which is used, which you use to ventilate each lumen separately. So you connect first to the bronchial lumen. So once you connect and you ventilate, while ventilating, you auscultate and slowly inflate the bronchial cuff till only that side is ventilated. Similarly, when you disconnect and you connect the connector to the tracheal lumen, you inflate and auscultate. Only one side is ventilated, right side or left side, depending upon the side in which the bronchial tube or bronchial lumen is inserted. So when you connect both, you auscultate. There is bilateral equilateral entry. So there are three commonest methods used to identify the placement of double lumen tubes. The gold standard is the fiber optic flexible endoscope technique, which is recommended for all cases, more required for right-sided tubes because you can identify where exactly is the right upper lobe bronchus orifice located. Okay, so that helps you to know exactly where the right-sided DLTs are placed. Well, coming to hazards of DLTs, the most commonest is difficulty in insertion and positioning in the first timers or beginners. As you know, it takes time. It requires some expertise to insert these tubes. And if you have multiple attempts, it increases the risk of traumatic injury. Many times what happens, the tube is rigid and does not allow for pre-shaping of these tubes. so as to have the curvatures. The large bit can't pass through a tracheostomy on the small airway when you want to pass through a nasal intubation. So it is very difficult. So these are some hazards or difficulties which you experience when you choose a DLT for isolation of the lungs. This is another thing, important thing which can happen with DLTs. It can get malpositioned, especially when anatomy of the patient is distorted and makes it difficult to place the DLT. And malpositioned tube can lead to unsatisfactory lung collapse. It can lead to obstruction of the lung inflation, what is required, and it can sometimes lead to gas trapping, which can lead to air trapping, which can have a significant cardiac embarrassment and cardiac collapse as well. So I just have a picture here wherein there are different major malpositions of a left DLT. Okay, here you can see the picture on the left side of the screen or the right side of the screen is a properly, correctly placed DLT. The first picture in the small screen, the small area, is too far on the left side. Both the lumens are on the left side. Then the middle one, it's too high up in the trachea. Both the lumens are in the trachea, and it's very you won't be able to isolate the lung. Similarly, on the right side, both the lumens are on the right side, and you won't be providing ventilation to the left side here. So there are common malpositions which can happen in a double lumen tubes. Major thing which can occur with DLTs are hypoxia. Maybe one of the most commonest cause for hypoxia may be malposition. So need to recheck the insertion of the DLTs. So you have to make sure that once DLT is inserted, after checking its position, then also when the position for surgery is given, then also you need to check, because the incidence of malposition after changing the position is there from 3 to 10%. The incidence of malposition is seen when you change the position for surgery. So you need to check tube positioning. Once these, I'll be talking about the hypoxia thing later on. This is one of the commonest, one of the problems associated with DLT insertion. One word about DLTs and difficult airway, which is very challenging in patients with a difficult airway. So their use as DLTs, though are commonly used, they can cause significant airway injuries, hypoxia, and so on and so forth. Therefore, we need to have alternatives for DLTs whenever you are faced with the difficult airway, basically bronchial blockers and single lumen endobronchial tubes. This is an algorithm. I don't know whether the picture is clear on the screen. Okay, difficult airway management, predicted and unpredicted difficult airway. So whenever there's a predicted difficult airway, you have to prepare yourself to go for a awake fiber optic assisted tracheal intubation with endotracheal tube or a double lumen tube. If you have passed endotracheal tube, then you need to use a bronchial blocker and provide one lung ventilation. If you have otherwise, you need to exchange to double lumen tube or a airway exchange catheter. When it is unpredicted difficult airway, when you're providing a lung separation, then you need to just ventilate the patient with face mask, and as with other difficult airway management, go for LMAs, then go for other adjuncts or other laryngoscopes to pass a double lumen tube and provide one lung ventilation. A brief word about in pediatric patients. There's some specific differences here. Though they fare better with healthy lung in the up or non-dependent position, the FRC is closer to residual volume, and small airways alveoli are more likely to collapse because the hydrostatic pressure between the dependent and non-dependent lung is less pronounced than in adults. And also the oxygen consumption, as you know, is much greater than in adults. So what are the techniques which are used to provide one lung in pediatric patients? The single lumen endobronchial tubes with small bronchial curves have a larger margin of safety than the uncuffed single lumen endotracheal tubes. But for emergency situations, you can use the normal ETTs. The Fogarty catheter can be used for bronchial blockers, a size 3 for children up to 4 years, and a size 5 for children from 5 to 12 years age. Balloon tip bronchial blockers remain the technique of choice under the age of 6 years, and they are also favored in an intubated or patients with tracheostomy. This is another addition to a pediatric double lumen called as Mararo's pediatric biluminal tube. It is nothing but the assembly of two uncuffed tubes which are joined parallel to each other. The shorter one has a tracheal part and the longer one on the bronchial part. It is safe and effective for use in children up to 3 years of age. Now coming to one lung ventilation properly, first you need to identify which kind of patients can go into hypoxemia. How can you predict patients going into hypoxemia? There are some factors which can be identified here. One is the site of operation. As you know, the right lung is larger than the left lung. Therefore, any operations on the left lung, so when there are operations on the left lung, the right lung gets ventilated. This will result in a better oxygenation than when the right lung is operated. Okay, then we are left with the left lung to be ventilated. It has been seen in literature that whenever you ventilate lungs, these lungs isolate with isolation with FiO2 of 1, the PaO2 achieved with the right lung ventilated is much more. It's around 250 plus mm of Hg compared to a left lung which is around 100 mm of Hg. This is in literature seen. Other factors which can come into play are the lung function abnormalities. Though it may not be accurate as predicted in the lung function, a lower PaO2 in the preoperative in ABG is highly predictive of low PaO2 during one lung ventilation. Also, depending upon the tumors placed which are there in the lungs, it has seen that the large central placed tumors they have a better preserved oxygenation during one lung ventilation because in the large central tumors, the perfusion is not well maintained in these central tumors. So when you provide one lung ventilation, the perfusion goes to the ventilated areas as compared to conditions where the peripherally isolated tumors are present. So this is one in literature identified that large central tumors preserve better oxygenation during OLV. As mentioned during in the before positioning, as you know, the left lateral decubitus position maintains a better OLV as compared to supine or semilateral because due to gravity, the perfusion as well as the ventilation is matched well and the oxygenation or hypoxemia is avoided. Coming to prevention of hypoxemia during one lung ventilation. So how do you prepare this? Basically, before you take off for surgery, you do a lot of breathing exercise. You give incentive spirometry for these patients. Whenever indicated, you can do postural drainage, use just percussion, which can increase the lung functions. At the same time, use bronchodilators in cases of COPD or borderline bronchial asthma patients, and also abstinence from smoking for at least 8 weeks, which can improve the lung function. Later on, once you do a lung separation, as I mentioned before, proper positioning and fixation of the tube by fiber optic confirmation is mandatory before the surgery starts. That is, once after giving position for surgery, it's mandatory that you confirm it through fiber optic, the exact position of the DLT, because any proximal migration can lead to no ventilation of the respective lungs which are isolated, so there's no lung separation. So similarly on the right side, if it's not placed properly, the right upper lobe may not be ventilated and it can lead to significant hypoxemia. Now coming to ventilatory strategies during lung isolation, compared to a normal tidal volume ventilation, low tidal volume ventilation is preferred because, as you know, when you give a higher tidal volume, it can cause some sort of polytrauma. It can increase inflammatory changes within the lung. And when high ventilation is provided, when high tidal ventilation provided, along with the high FiO2, it can lead to atelectasis. This is in relation to low tidal volume. Sorry, in low tidal volume, when you give ventilation with a higher FiO2, it can cause atelectasis of the distal alveoli. So this makes us use PEEP for providing lung ventilation in these lung isolation manuals. So what is the ideal PEEP? There is a lot of controversy regarding what is the ideal PEEP required to maintain oxygenation in one lung ventilation. Many of them advise more than 10. Some of them say around 5 to 10 is acceptable. The optimal PEEP here is the one where the end expiratory pressure is at the low inflection point of the static compliance curve. So this is the ideal PEEP which is required to maintain to prevent hypoxia and maintain arterial oxygenation. Similarly, you need to maintain the plateau pressure less than 30 centimeters of water. So whenever it exceeds this more than 35, it can cause barotrauma and lead to mismatch in ventilation and perfusion. Another point which has to be noticed here is the FiO2. The FiO2 has to be maintained minimal so as to maintain SpO2 more than 90%. Many times what we do is we try to keep a FiO2 of 1. So keeping a FiO2 of 1 is going to mask your hypoxemia till the end. Okay, by giving a lower FiO2, it will help you to detect hypoxemia early. So once you detect hypoxemia early, your other manuals like or confirmatory or corrective manuals like identification of DLT and mode of ventilation, application of PEEP can set in so that you can avoid hypoxemia later on. So you try to maintain a lower FiO2 initially so as to maintain a SpO2 of around 90 to 92%. Permissive hypercapnia also is a beneficial thing because, as you know, hypercapnia can increase or maintain HPV, hypoxic pulmonary vasoconstriction, and maintain the ventilation perfusion match. Coming to the last one, mode of ventilation, it is seen that pressure control ventilation provides a more uniform distribution of tidal volume compared to a volume controlled ventilation and can hence improve oxygenation in one lung ventilation. Type of anesthesia, there is not much difference in the type of anesthesia. It can be the different drugs used or different agents used. Volatile, though known to inhibit, there is not of much significance. Intravenous anesthetics have no effect. Even epidural anesthesia, many times what we practice is general anesthesia plus epidural anesthesia, post-op analgesia. It also does not interfere with HPV. So basically, there's no a proven type which is beneficial over the other. The other factors which can lead to decrease in the oxygen saturation of the shunted blood are low cardiac output status, any increased tissue oxygen extraction, and low hemoglobin levels. All these three factors can lead to arterial hypoxemia whenever one lung ventilation is done. Now, what do you do once hypoxemia occurs during one lung ventilation? What are the steps which you need to follow? First and foremost is to identify and treat the most common cause. So basically, the first thing what you do is you increase the FiO2. After you increase the FiO2, the immediate next step what you do is you have to check for the tube placement. Okay, immediately you check the tube placement. If you can use the fiber optic, it is available. Otherwise, again, you have to go back to the oscillatory method. So you see whether it is placed properly or it has migrated or it is misplaced. Okay, which is the most common cause for hypoxemia to occur during one lung ventilation, that is tube misplacement. Next is cardiac output. Many times hypoxemia may occur due to low cardiac output. So you need to check on the volume status of these patients and try to maintain adequate cardiac output. Next thing, what you do is what is called as lung recruitment maneuver. So here, what you do is you give a single recruit maneuver of a ventilation of with the inflation pressure of 30 to 40 centimeters of water for 10 to 20 seconds. Okay. So by doing this, if at all, this maneuver vastly improves oxygenation, it reduces shunt fraction and dead space ventilation. So once you know that there is a lung recruitment which happens here, then you can apply PEEP. So to the dependent lung, any improvement in the oxygen index after lung recruitment is an indication for the application or increase sequentially in the level of PEEP to the dependent lung. Similarly, to the non-dependent lung, you need to apply a CPAP of as low as 3 to 5 centimeters of water, which is found to be effective in preventing hypoxemia. Another techniques which can be used to treat hypoxemia in one lung ventilation is use of vasodilators and vasoconstrictors. Vasodilators to the dependent lung and vasoconstrictors to the non-dependent lung. Vasodilators to the delivered directly into the dependent lung without disturbing the HPV which exists in the non-dependent lung can be achieved only through inhalation, that is through inhalation vasodilators. Basically, there are the three known inhalation agents which can be used: nitric oxide, prostacyclin, and aprosodil, that is PGE1. The vasoconstrictors which are given intravenously is almetril, which is a respiratory stimulant, which is known to potentiate HPV and improve oxygenation. It is best used in combination with inhaled nitric oxide with a dose of 4 micrograms per kg per minute. But the only disadvantage of almetril is it can increase pulmonary resistance, pulmonary vascular resistance, and cause a strain on the right ventricle. The other things which can be done is physical restriction of pulmonary blood flow, a complete or partial clamping of the pulmonary artery. But as you know, this requires a higher exposure, and this occurs at the expense of increased right ventricular strain. The other advanced techniques which can have impact on the surgical exposure is partial ventilation or apneic oxygenation or CPAP. As I mentioned before, CPAP to the non-dependent lung is the best option to improve oxygenation during one lung ventilation. But it is known that surgical interference will occur whenever the applied PEEP is more than 10 centimeters of water. Another maneuver which can be done is subsegmental intermittent positive airway pressure. For this to apply, you need to know the anatomy of the segmental anatomy of the distal airways. How it is done? It's usually done through a fiber optic. You pass a small oxygen supply, and the effect of this is known only if you give a prolonged oxygenation for longer time with a CPAP of at least 5 centimeters of water. Well, this comes to my end of my lecture. I hope it was quite informative. Coming to the quiz questions, Sri Ganesh.
Yes, sir. Please go ahead. I give some time of around 10 to 15 seconds.
For
then
each.
You can go to the second. For
each.
Yeah. I think people have already started. You can go ahead.
Yeah, during one lung ventilation with a double lumen endotracheal tube, the following are most likely to be causes for hypoxemia related to high airway pressure, except the options are weight of the mediastinum in the lateral decubitus position, train of 4 ratio on aorta policy of 0.9, pneumothorax, shunt in the non-ventilated lung. So we need to.
Yeah, just 10 seconds for them to type the answers. Please type the question number as 1 and then your option. And please use your name, not the device name. We will not be able to identify the person if you log in with your device name.
Chat box.
Yeah, people are answering in the chat box, sir. You can go to the next question, second question, sir.
Okay. Second question is, to treat physiological hypoxia of one lung ventilation, the following strategies are likely to improve oxygenation: insufflation of oxygen to the non-ventilated lung, optimization of hemoglobin cardiac output, high frequency jet ventilation, nitric oxide, all of the above.
Again, I'm requesting, please use your name, not Galaxy or OnePlus, etc. They will not be considered for the certificate because we will not be able to identify who that person is. And these questions for this talk are open to postgraduates only. And the next talk, the quiz questions will be for the practitioners.
Can I go to the next one?
Yes, sir. Please, sir. Third.
Endobronchial bronchers for lung isolation are most likely to be appropriate in the following situations, except options: patient 1 centimeter tall, ventilation on critical care after esophagectomy, patient Mallappati score of more than 4, and in case of hemoptysis.
Yes, sir. Thank you, sir.
Fine. Well, to summarize,
yeah.
as is well known, DLTs are the most favorable devices for one lung ventilation. The lung protective strategies for these are low tidal volume with a PEEP of 5 to 10 and the P plat of less than 30. No definite advantage of the type of anesthesia of one or the other. If hypoxemia develops, see that you confirm the DLT position properly. Use CPAP to the non-dependent lung. Maintain adequate cardiac output and hemoglobin, and switch to two-lung ventilation if all these maneuvers or interventions are not helpful. Well, thank you. Thank you for patient hearing. Thank you, everyone. We are obliged to answer any of the queries or questions.
Yes, Dr. Rajesh, there are a few questions. Of course, many of them you have already answered. I just wanted to, some of them may be repeated. Just the first thing is, in children, which side do you prefer, whether it's a right side or left side? Even though you use probably the single lumen tubes and all that.
Yeah, prefer the right side.
You prefer the right side, okay.
Right side.
That is because it can be easily inserted.
Easily inserted.
But what do you think about the obstruction to the upper lobe?
That is the thing, because we need to really identify the placement of the endobronchial tube. If you are using it as an endobronchial tube, we need to confirm it through fiber optic. That is very difficult.
So that is one of the aspects.
Yeah.
You partially explained this in difficult intubation situations. Would you like to do straight away awake intubation, or awake intubation and double lip tubing, or you can use other methods as well?
In a difficult intubation, it's better to do awake intubation, because first of all you're going to pass a double lumen tube as indicated, and if at all you tend to traumatize, if you like to do with a conventional technique, then that's going to be more hazardous, and you won't be able to go back to the option of you doing a fiber optic, which is going to bloody your airway, and hence it's going to be very difficult. So if you see that, if you confirm that it's a difficult airway, then it's better you go for a awake fiber optic intubation.
Okay. But suppose you suddenly come across unexpectedly that there is a difficult intubation and you're not able to pass the tube.
Yeah. Then as in any other difficult airway algorithm, you need to pass a LMA. Over the LMA, you pass an endotracheal tube, normal endotracheal tube, take a tube exchanger, and through it you can pass a double lumen tube, which can be confirmed through a fiber optic bronchoscope.
You can also use bronchial blockers in such a difficult
in a
situation.
difficult,
That's the best thing.
as I told before, bronchial blockers are indicated in a difficult airways.
Yeah. There is one question from Dr. Gurudhar. Should we always ventilate with FiO2 of 1? You did mention that you should have lowest possible oxygen levels. You
Correct,
should confirm about 90% of this thing. Is it?
Yeah, correct. Because as I told, you institute low tidal volume and high FiO2. So both these can lead to distal atresis. Therefore, so if low tidal volume with the PEEP with a low whichever effective FiO2 is more preferential, and as I told before, it is high FiO2 can mask hypoxemia till the end. So it may just take hypoxemia may just set in then. So then it's very difficult for you to do any corrective maneuvers. So it's better you start with the lower FiO2 so as to maintain a saturation of at least 90 or 92%.
You did mention about ventilation settings. Now, what is the ventilation settings you use during OLV? And you also mentioned about permissible hypercapnia.
Yeah.
So what level do you allow it to go?
Permissive hypercapnia is usually indicated up to 60 mm of Hg, 60 to 65 mm of Hg, because it itself can, any increase in the PCO2 again can have a adverse effect on the intracranial pressure. It increases sympathetic stimulation. It's going to affect the cardiac output. It's going to increase the pulmonary resistance. So the permissible level is around 60 or 65 mm of Hg.
Okay. Now, about volume ventilation versus pressure control ventilation. I think you have already said that it is better to go in for pressure control ventilation.
Pressure control.
Isn't it?
Because
now, one more question is,
go
ahead.
Go ahead.
Now, see, we know that cardiac output is also dependent upon hemoglobin level. What is the lowest hemoglobin level you will accept before taking the patient for OLV? And what is the transfusion triggering? Or it's almost same anyway.
It's almost the same, around 7 or 8.
What level of hemoglobin would you accept?
See, hemoglobin depends upon the underlying condition of the patient, the cardiorespiratory status of the patient. So anywhere between 8 to 10. Okay, in a normal patient, we go up to 8 HP level. In a compromised with a cardiac compromise or a lung pathology, we tend to have a higher HB of 10 at least. So it's 8 to 10, anything between 8 to 10, depending upon the underlying cardiorespiratory condition of the patient.
Okay, one last question. There is one question about, is Dexam is going to cause any changes in the this one, hypoxic ventilator?
Which one?
Hypoxic pulmonary vasoconstriction. Dexmedetomidine infusions.
Dexmedetomidine infusion.
Does it change or it has no effect on that one?
I'm not aware of this. I'm not aware of this.
Okay.
Right.
That's right. So very good.
Param sir, there are 2 more questions.
That's what I was about to go to that one.
Please sir, go ahead sir.
So
Param sir,
what is the effect of AC inhibitors on HPV? Do you need to be cautious on that one?
AC inhibitors have some sort of effect on the HBV. Then they tend to abolish HPV.
Okay.
AC inhibitors.
So should we stop it before if somebody is taking that?
They have to be stopped before.
Okay.
Gurudhar sir, I think Gurudhar sir has one question. IV versus inhalation. You want to ask sir, Gurudhar sir?
He had already answered that.
Many of the students do ask about one particular question. Actually, Dr. Param already asked Dr. Mane about it, especially about FiO2 because we know that every 2% increase in shunt is going to decrease the PaO2 by 50 millimeters of mercury. So you know that once you go for a one lung ventilation with the dependent lung being healthy, you will have almost nearly 28% of shunt. that means the PaO2 should decrease by 700 millimeters of mercury. So even unless you use FiO2 1, you will not be able to maintain a saturation of above 90%. So this is one common question every postgraduate used to ask me. So that's why I just put that as a question there.
Okay. If the technique of lung isolation is perfect, and with hypoxypulmonary vasoconstriction playing a significant role, I feel FiO2 of 1 may not be required always.
No, but provided you also give some amount of oxygen to the non-dependent lung.
Yeah.
Like about 2 to 3 or 5 liters of oxygen with some CPAP, then you don't require. Otherwise, you may require because many times the dependent lung can be diseased also. It may also have some disease.
So
then you
there's
have
so many
problems.
factors.
Another question I just put for the postgraduates' sake is TIVA versus inhalation anesthesia for one lung anesthesia. Which one may be better? Because we know that inhalation anesthetic agents do have some amount of effect on the hypoxic pulmonary vasoconstriction.
Right.
Whereas IV agents absolutely do not have any effect. Plus, the inhalation anesthetic agent, when you are using a one lung only, the depth of anesthesia we may not be able to maintain.
Absolutely.
So, is it a combination is better, or total intravenous anesthesia is better, or inhalation anesthesia is better? What do you suggest?
As you appropriately mentioned, intravenous anesthesia is more preferred to inhalation agents, as the points you have clearly mentioned. I think they are better, I believe.
Right, so thank you.
Sir, there is one question from Dr. Anil regarding what is the permissible airway pressure during OLV?
Permissible airway pressure.
P-plat of 30.
Venugopal sir, you have any comments or questions, sir?
No, everything is fine.
Okay.
Excellent.
Thank you, Mane sir, for excellent presentation. Very clear.
Excellent presentation. Good questions also. Good participation from everybody.
Yeah.
Okay. Thank you from my side also.
Yeah. Thank you, sir.
I thank the moderator, Dr.
Param sir and
Parmeshwar and
Venugopal sir.
Yeah. Thank you, sir. Thank you very much.
Before we move to the second talk, and before I invite Venugopal sir to introduce, I'll just share our conference details for benefit of viewers. Is the conference screen visible to all?
Yeah.
Yes.
So this is our ISA Karnataka State Conference scheduled on 12th and 13th December, second Saturday, Sunday. I request all the participants who are logged in and their friends to please register. We have already crossed 1,200 registrations and 98 abstracts. We have also quiz open for postgraduates of Karnataka. Different colleges can participate. And please access this conference website at event.isakarnataka.org or isakarnataka.org. Now I request Venugopal sir. Yes, sir.
I have a request.
Yes, sir.
For this conference, just want to know whether the abstract submission can be extended for some more days.
As of now, it is 15th. Yeah. Please try to submit it before that. We will see. We might extend by a few days.
Yeah, because of COVID and all that.
Yes, sir.
We understand. Because many of our postgraduates were doing COVID duties, so they were off OT work for a long time.
Yes, I agree, sir. We will extend by a few days, and fortunately, COVID is coming down everywhere, I think.
Yeah, I know. Fortunately.
Yes. Yeah. Thank you, sir. Venugopal, sir.
Yes.
Please, Dr. Latkar can share your screen, and then Venugopal sir can introduce, and he can.
Yeah, fine. Very good evening, the respected senior teachers, Dr. Gurudat sir, the advisor, Academic Committee ISA Karnataka, Dr. Bal Bhaskar, Chairman ISA National Academic Committee and past President ISA National, Dr. Vijayanand, President ISA Karnataka, Dr. Sri Ganesh, Secretary, Dr. Shivkumar, Vice President, and both the speakers, Drs. Rajesh Mane and Dr. Latkar, and Dr. G. Parmeshwar sir. Very good evening. Welcome all. Dr. Rajesh Latkar is the second speaker today. His topic is the regional anesthesia and private practice, then overview. He is the private practitioner in Bangalore. I welcome Dr. Rajesh Latkar. Please go ahead. Thank you very much.
Am I audible to all?
Fine.
Yes, sir. Audible and visible.
Yeah. So myself, Dr. Rajesh Latkar, practicing in Belgaum. Just want to correct Venugopal sir. I am practicing in Belgaum, Karnataka. Okay. Good evening, one and all. And thank you, Dr. Mane sir, for excellent presentation on one lung ventilation. So at this outset, I like to thank all the office bearers of Karnataka State Chapter, then Dr. Balabhaskar sir, Dr. Gurudat, then Dr. Vijayanand, Dr. Shivkumar sir, then Sri Ganesha, and Dr. Parmisha. So here I am in the galaxy of gods of Karnataka. So anesthesia, you all know, it has evolution of anesthesia from 2000 BC to till date. So big event on 1846, then 2000, and then now in 2020, we are saying we the private anesthesists are sitting on the chair and monitoring. So this is my quiz for all. The anesthesiologists are intelligent, funny, attractive, all of the above. Okay, so this is quiz first. Who gave the demonstration of ether anesthesia in 1846? Is it Dr. Crawford Long, Dr. Horace Wells, Professor James Simpson, or Dr. W.T.G. Morton? So this was our first quiz question. So I'll have to wait for 10 seconds, as Dr. Sri Ganesha said.
I don't think anybody can get this wrong, sir. Such a easy.
Okay. So my topic here is regional anesthesia in private practice. The scope of topic is very huge. So I made it very precise. So I'll be going only for central neurological block, that is spinal, epidural, and if time permits, I'll spoke a little bit about IV regional anesthesia. So spinal anesthesia, so there are a lot of advantages of spinal anesthesia, especially for private practitioners like us, because that is the safest anesthesia. If anesthesiologists have a knowledge of anatomy, physiology, and pharmacology of local anesthetic, then this is the safest possible anesthesia for all. Its work out very cheap. If you compare it with GA, inhalation, as well as IV anesthetic drug, it works out very, very cheap. And added advantage of spinal is there is decreased blood loss. Because there is vasodilation, as you all know, there is pulling of the blood in the extremities. So blood loss is considerably less. And if you compare with general anesthesia, there is always tachycardia. So blood loss is always more under general anesthesia, and you have to give more inhalation anesthetic agents to control that blood loss. Good muscle relaxation is another advantage. You have a very good muscle relaxation, especially below umbilicus surgeries. Then there are decreased chances of DVT. So it is proven that chances of DVT are very, very less, especially in major hip surgeries. Then maintaining patient airway, patent airway. So already patient is awake under spinal anesthesia. So there is no need for any airway maintenance and all. So this is added advantage for spinal anesthesia, especially for private anesthesiologists. So there are some disadvantages, like it causes hypotension. So whenever you give spinal anesthesia, as you all know, there is hypotension because of sympathetic blockade. So sympathetic chain is blocked. So very minimal dose also can cause hypotension because sympathetic fibers are blocked first. So hypotension is common with very minimal dose also. So it is not dose dependent. And then many patients, they prefer to sleep. So in these patients, you can't give spinal anesthesia. Then patient can talk between surgeries, so that irrelevant talk may be sometimes irritable for surgeon also. So that point also should be considered. And for these patients, we have to give some sort of sedation. Spinal anesthesia is not reliable for surgeries over 2 hours, because whatever you give, if you add opiates also, then relaxation part usually lasts for 1.5 hours. So excellent relaxation for especially hysterectomies and abdominal surgeries under spinal anesthesia lasts for say 1.5 to maximum 2 hours. So it is not reliable for surgeries more than 2 hours. But limb surgeries, you can go, they can go for, let's say, 2.5 to 3 hours. Then whenever whenever you puncture the dura, there are chances of meningitis are always there if you don't take sterile aseptic precautions. So aseptic precautions are must while administering any spinal injections. And there is theoretical risk of PDPH, that is post-dural puncture headache. So what are the indications? So indications for spinal anesthesia in private practice are all surgeries below umbilicus, like hernia, prostate, appendix, etc. So these are day-to-day surgeries in private practice. So almost 99% surgeries in the private practice are done under spinal anesthesia. So very few surgeries like ENTs and all we are doing under general anesthesia. Even all surgeries on the limb we are doing in regional anesthesia, except for shoulder, because like unavailability of USG guided blocks and all. So shoulder surgeries we are doing under general anesthesia. So surgeries in perineal region, there is added advantage. You can give administer anesthesia in sitting position, so that is saddle block. Then orthopedics, all the orthopedic surgeries, lower limbs, then genitourinary surgeries, and bread and butter of all anesthesiology is Caesar and hysterectomies. So these all surgeries can be done under spinal anesthesia. So what are the contraindications? So contraindications, the first contraindication is patient's refusal. So if patient doesn't want spinal anesthesia, you should not insist him for spinal anesthesia. You can counsel him that whatever anesthesia you are giving, spinal anesthesia you are giving, it is very good, you will be awake. But if patient insists he doesn't want anesthesia, then you should not go for spinal anesthesia. So that is the first contraindication. Then coagulopathy, that is absolute contraindication. For any to administer spinal anesthesia, coagulation profile should be done prior to that. And in private practice, private practice particularly, so platelet count should be this one more than 1 lakh, that we are following. But like books mention, it can be done. You can give anesthesia till 50,000 platelet count. So PT-INR, and if not available, then at least BT-CT should be done prior to administering any spinal anesthesia. So any infection at the site of lumbar puncture is absolute contraindication. So you should look for the back. Then raise ICT, intracranial tension is absolute contraindication for administering spinal anesthesia. Another contraindication is fixed cardiac output test, like aortic stenosis, then hypertrophic obstetric cardiomyopathy. These two are absolute contraindication. In mitral stenosis compensated, you can administer spinal anesthesia, you can give epidural, but like not for aortic stenosis. Then in heart block, because there is bradycardia, so that whenever there is heart block, so already the pulse rate is already low. So on that, you are adding another bradycardia, so that is detrimental for the patient. Then any pre-existing neurological disease, you have to consult them properly. Even in polio cases, we are usually giving spinal anesthesia, but before that, you have to explain to the patient that by giving spinal anesthesia, by puncturing at your back, we are not hurting you, we are not adding any other complications. So whatever your power in your limbs will be the same, whatever your existing disease will be the same, but it won't this one increase by adding this. Then severe hypovolemia is another contraindication. So you can give in hypovolemic patient, but that hypovolemia should be corrected prior to the surgery. So whenever there is blood loss, that should be in trauma, especially in polytrauma and all. So that blood loss should be replaced prior. You have to correct the hypovolemia, and then you have to administer spinal anesthesia. Then liver disease also is a relative contraindication, because of in liver disease that coagulation profile is always raised. So that so that point should be always be considered. Then any anatomical abnormalities of vertebral column, these are relative contraindications, like kyphosis, scoliosis. So there are difficulty while administering anesthesia. Then little bit about anatomy. So you all know spinal cord ends at L2. important landmark for all of us is a line joining top of the iliac crest, that is L34. So spinal anesthesia preferably should be given at L34 or maximum at L23, but never above L2, because in 2% of cases the spinal cord ends below L2. So in that cases, you may end up harming the spinal cord. So that should be keeping in mind. So what are the structure our needle pierce before reaching the CSF that you should know? So you have the supraspinous ligament, interspinous ligament, ligamentum flavum. Ligamentum flavum is usually a thick structure. So there is certain click while this one, whenever you pass through that ligamentum flavum. So that click you should appreciate, because that will help you during the learning curve of giving epidural. So whenever that click, you are like piercing through the ligamentum flavum, and then you will enter that epidural space, and then dura is the toughest structure. And when you like pierce the dura, then CSF flows, and when the CSF flows, then only you have to give the injection. So what are the practical implications in this? So suppose while giving the injection, if there is blood instead of CSF, so you are this one in the vein, epidural veins, maybe like there are engorged epidural veins. So this problem is common in pregnancy because of like the pressure of gravid uterus. There is raised intra-abdominal pressure, so that transmits to this one on the spinal column, and that epidural pressure is raised, so that veins are engorged in the epidural space. So when you like insert the LP needle, so there is blood instead of CSF, and when there is blood instead of CSF, instead of removing it, you just have to advance it a little further. So that is one technique. You have to just advance it a little further, so that you will pass that you will puncture that vein through and through, and you will again enter in the dura. So this is one technique you can try. Then, as I mentioned, in 2% cases, this one spinal cord ends above L2, so you should not give the subarachnoid bulb above L2 level. So you're taking so many pricks. So this is a like while learning curve, you should understand that certain click sensation of ligamentum flavum, and then you have to then you will be in the epidural space and dura. So there are two click sensations. So that two sensations you have to learn during your learning curve in PG days. Then what are the contraindications? These are continuing contraindications. Patient's refusal already I have talked. Then absence and deficiency of equipments for resuscitation. So this is an absolute contraindication, especially in private practice. At institute, you have all the like resuscitative equipments, including difficult airway set, and every equipment for intubation is already ready. You have all PGs there, so already help is already there. But for us in private anesthesia, you himself has to look for each and every instrument in the OT, because many places, especially in the periphery, there is not even boil separators. So still you this one, so that have to it is hardly used, like sparingly used, so that all parts you have to check. So absence of any GA drugs also is contraindication. So whenever you are giving any spinal anesthesia, it is not that you don't require GA drugs. So GA drugs are a must. So intubation facility should be there in any OT, especially in private setup, and oxygen availability of oxygen. So if it is there, then only you have to give spinal. Then clotting abnormalities already I have mentioned. Then liver disease, infection of the bag, this is already mentioned. Then in uncooperative patients, like some like pediatric patients. So in pediatric patients, it is very difficult to give spinal anesthesia unless you sedate them. So in pediatric patients, little bit of sedation, ketamine, it will help before giving spinal anesthesia. So septicemia also is a relative contraindication. So whenever there is septicemia, you have to correct it. This one prior. Neurological disease already mentioned. Patients on anticoagulation. So this one long-acting anticoagulants, warfarin and all, it should be stopped prior to this one giving spinal anesthesia. But now the short-acting like Clexane and all, you can stop 12 hours prior. Then eclampsia is relative contraindication. You can nowadays we give spinal for even eclampsia patient. Pre-eclampsia, we usually give spinal epidural. Eclampsia, usually we give epidural. But spinal anesthesia, because like you may end up in convulsion, and all chances of convulsion are always high in eclampsia. So that point should be considered, and like you have to judge it. So like whether giving spinal or GA, which is better, that you have to judge prior to going for spinal for eclampsia. But for pre-eclampsia, you can definitely go for the epidural anesthesia. So that is best for that. The reluctant surgeon is another relative contraindication, but some surgeons, they like don't want spinal anesthesia for especially abdominal surgeries, but you have to explain them properly, and if they are not ready, then you don't have choice to go for general anesthesia if the facility is available at that setup. Then little bit about physiology. There are three types of nerve fibers, you all know: sensory, motor, and autonomic. Whenever you give spinal anesthesia, that autonomic fibers, they block first. So hypotension is the first sign of spinal anesthesia. So that everyone should keep in mind. So proper hydration, even proper hydration is must, preferably by large IV cannula. So that is a simple method to avoid hypotension by preloading. So in preloading also there is now a concept of co-loading. So whenever you want to give two fluids, just you give one fluid prior to anesthesia and one fluid when like just you are starting for LP and all. By that time you can give one fluid by large IV bore needle. So local anesthetic, there is three types of local anesthetic agents: hypobaric, isobaric, and hyperbaric. But in private practice, we use hyperbaric only. Most commonly used in private practice is 0.5% bupivacaine, lignocaine 5% heavy. That use also has been we are sparingly used nowadays, because there is no added advantage of lignocaine over bupivacaine, even for minor cases and all. Then like what is the procedure of LP? Pre-operative visit should be there prior visit, but it is not possible in private practice, because private practice we have to move from here to there, many places we have to go. So it is not possible for us to visit the patient pre-op. And then pre-medication, pre-medication you can give like in uncooperative patients or in children, as I already told. You can give little fortine, little tramadol. Even ketamine can be used as a pre-medication in pediatric patients. Then preloading is a must. So preloading for spinal anesthesia, usual for hernia and all, you can give one fluid. For obstetrics patients, you can give at least 1 liter of preloading and 1 liter, 0.5 liter of co-loading. So 2 to 3 bottles of fluid should be given prior to delivery of the baby. Then positioning. There is difference between male and female. Just I will go. There is little difference between male and female. In female, there is wider pelvis, so that whenever you are giving anesthesia in lateral position, so there is always little head low in female patient, and in male patient there is wider shoulders. So there is always little head up in male patient whenever the table is in neutral position. So you have to see the spinal column, not the table position. So table position may be neutral, but spinal column in female is little head low. So that spinal column should be corrected. So lateral versus sitting, it is personal choice. You can give either in lateral position, you can give in a sitting position, whatever is better. Sitting is better for even obstetric patients, because the gravid uterus and all, the abdomen is huge, so they are more comfortable in sitting position. Lateral position, you need like proper assistance, because that leg should be curled up. So leg should be held in that curled up position. So proper explanation to the patient is must, because in private you don't have many hands at your disposal. So you have to explain the patient properly. Patient should not move during the injection. That is a prerequisite. And if he doesn't move during the injection, neutral position also is fine. Even in lateral position, even neutral position is fine. Then position of the anesthesia, you can either sit on a chair, or you can directly give like that. Then what are the factors affecting the extent of the block? So level of the injection, spinal doesn't matter, because spinal usually we give in L34 or L23 level, but preferably L34 is better. So we can't give higher than that. So level of injection matters for epidural. but it matters a little in spinal, not much. The position of the patient is that affects. So whenever there is head low position, then block tends to go high. Head up position, block tend to be in the sacral position. So you can block the sacral segment ST234 by saddle block by keeping the position, keeping the sitting, maintaining the sitting position for say 3 to 4 minutes, so that saddle block can be well achieved with minimum dose of the injection. So speed of the injection, it also matters. So like you never give injection hurriedly. So two problems with the speed of injection: whenever you give the injection hurriedly, the chances, because nowadays we are using smaller bore needles, 26 gauge needle, 25 needle. So whenever you give injection speedily, the chances of spillage is always there. So that one point you should keep in mind. And second point, like physiologically there are eddy current develop while you give fast injections through the CSF. So that height of the block will not be reliable for speed of the injection. Then drug concentration and volume, it depends on the drug. Xylocaine for say 45 minutes procedure, and like bupivacaine for say 1.5 to 2 hours. Then concentration, usually we use 0.5%. And volume use, it all depends on volume. So like for upper abdominal surgeries, you big say 3 to 4 cc is required, and for say limb surgeries 2.5 to 3 ml of bupivacaine is sufficient. Then for saddle block also, like 2.5 cc is sufficient for this one fistula in ano or any anorectal surgeries. Then varicity, as I mentioned, it like 0.5% usually we give bupivacaine heavy. So by adding the dextrose, this one it tend to sag by gravity. So adding dextrose, so that varicity affects. Then barbotage is a technique some people they follow, we don't usually follow. So while that CSF they take in the syringe and again they inject, taking the syringe a little and again injecting. So senior anesthesiologists here, they practice this technique, so that increases the block. Then patient factors like age, height of the patient matters. So normal level for common procedures are upper abdominal surgeries, usually T4-5 level is sufficient. Lower abdominal surgeries, T6 to 8 is sufficient. Then for prostate, usually T10 is sufficient. So around say 2.5 cc or 0.5% bupivacaine is sufficient. Then for limb surgeries up to L1 and perineum, as you know, S2 is sufficient. So there are different type of spinal needle, pencil point and like Vitacare and all, with different diameters. So in private, usually we use is 26 gauge spinal needle, because you know that the finer is the better. So PDPH, the post-dural puncture headache, is more common with like whenever you puncture the dura accidentally by say 16 to 18 gauge needle. In that case, almost there are say 25% chances of PDPH is there. But when you use smaller needle, say 26 gauge, the chances of PDPH is very less. It is hardly 2%. So this is a book by Atul Gawande, a renowned surgeon practicing in US. So the checklist manifesto. It is a must-read book for all. So how to get things right by making a checklist of everything. So what is a checklist before administering any regional anesthesia or any spinal anesthesia? So you should go through the case sheet. So you should read the case. You should name, age, whatever it is, surgery, what surgery the patient is posted, and then you should see for the consent. So proper consent should be taken. So suppose the patient is suffering from polio, and you have to give spinal, then you have to explain to them about the neurological things, because medico legally that is the most important thing. Even for suppose preeclampsia, you have to give spinal anesthesia, then you have to explain them about the possible complications. So you have to talk with the patient, you have to consult the patient, and then you have to administer the anesthesia. Then proper evaluation of the patient is must. Then check the IV lines, monitors, availability of the oxygen. As I mentioned, resuscitation equipments like laryngoscope, tubes, airways should be in the place. Then while administering this one spinal anesthesia, strict aseptic precautions is must. So that is the first thing, because see, like whatever there is meningitis, that chances of meningitis are because of we are not following aseptic precautions. And one is the chance of chemical meningitis is always there because of betadine. That's why that betadine, whenever you apply that betadine, it should be wiped off cleanly with spirit, and then you have to do the LP. Then read the label of the ampoule. So whatever injections you are giving, you should read it properly, because there are, like now we give 0.5% bupivacaine, so that is 4 cc ampoule. So now many injections have come are 4 cc, even Lasix come in 4 cc. Then this one pause injection, like tranexamic acid. So accidental injection of tranexamic acid is quite catastrophic, and we have like report in our journal, 2 to 3 deaths have been reported because of accidental injection of a drug like tranexamic and all. So read the label of the ampoule like before this one. In private practice, we used to there are not many handset disposable, so you have to take the ampoule properly, you have to read the ampoule, and then only you have to take. Load the ampoule yourself, because whenever you go, you ask the patient, like you prepare the patient, you take put the trolley and take the drug, and you go there and administer the spinal. So these things you should not do in private practice, because like that sister who takes that injection, if she may take the wrong injection, then you may end up giving the wrong injection to the patient, and then whatever complications are there, that are catastrophic. Then use, whenever you give like LA for say before giving LP, then make habit to use a separate syringe for LA, like coding. Suppose say you are using 2 cc syringe for LA, then use every time you use 5 cc syringe for administering anesthesia. So like there will be coding, 2 cc is for local anesthesia and 5 cc for this is spinal anesthesia. So don't spill injection while giving, because you never know how many drug you have spilled, and it is like again you may end up giving more drug. Then don't prick with sharp needle for assessment. That is this is the point must for every private anesthesist, because in the beginning we are apprehensive, and like we try to check the level by pricking with sharp pencil and all, sharp pin. So you may end up making holes in the skin, and that bleeding thing. So you may just one. Behind every back pain, there is anesthetist who is blamed for giving injections. So do not prick the patient repeatedly. So what are the troubleshooting for spinal anesthesia? So whenever you use any spinal anesthesia, after giving spinal, there is no block at all. So this thing may happen. So mechanism for this is, whatever drug you have given, that is not in CSF. So like there may be CSF while aspirating and all, but you may end up giving that drug in the epidural space, because through the capillary action, the CSF comes through the needle. But whenever you give the injection, the whole injection goes in the epidural space, and whatever dose we use, 2 to 3 cc, that is very, very insufficient for anesthesia. Then one more problem is block not high enough. So whenever there is block not high enough, you are using heavy bupivacaine. So you can make the table appropriate, like proper head low position, or one-sided, it is a limb surgery and all. Another problem is whenever you prick, there is no CSF. So these things may happen. Then blood flow from the spinal needle, as I mentioned earlier, even epidural vein, there is blood from the spinal needle. Then patient complains sharp pain in the legs. So if patient complains sharp pain, then you may near that nerve root. So just you have to withdraw a little, and you have to go in the midline. So hitting bone on repeated attempts, it may happen while giving the patients with scoliosis, kyphosis. Then block too high. If the block is too high, then there is sudden hypotension. So for that, all restriction, fluid restriction should be there. So that's why all the equipments for general anesthesia should always be ready while administering spinal anesthesia. Then there are chances of like nausea, vomiting is there. Then you have to administer MSET. So in pre-medication, that anti-emetic as well as H2 blockers are always necessary. So patient tend to shiver during anesthesia because we give 2 to 3 IV fluids fast, and then there are many patients factor because for cesarean section there is spillage of liquor, so there is shivering. So for that shivering you can control it with little sedation. In this case also tramadol and all will be helpful. So what is the treatment of hypotension? So whenever there is hypotension, make a habit that whenever you use anesthesia, there should be you should administer the oxygen, at least 2 to 3 liter nasal oxygen. So for that hypotension also, that patient will be comfortable. So each and every hypotension should not you should not rush on treating that. Simple leg raise also will raise the BP. So instead of making the head low like pendulum position, you should simply raise the legs. Increase the speed of IV fluid also can be tried because you are using wide bore cannula. So already you have fluid with 1 to 2 fluid. So you can increase the speed of the IV fluids. Then you can give atropine if there is bradycardia, because this peripheral pulling is there. So stretching of peripheral pulling of the blood, that causes hypotension. And in this one spinal anesthesia, that Benbridge reflex is predominant. So there is bradycardia. So whenever there is bradycardia, you can give atropine. Vasopressors also can be given. So there is controversy because there is vasodilation and there is peripheral pulling of the blood. So that can be countered by vasopressor, but each and every time it should not be given vasopressors. You should try first by the position, by giving oxygen, by IV fluids, and then you should try vasopressors. In vasopressors also, you commonly use ephedrine, not phenylephrine should not be used. Then this is a quiz 2 question. Dr. Shri Ganesha, please this one go
Yes,
through
sir.
this.
Please go ahead, sir.
Yeah.
Please go ahead.
So heart rate and blood pressure are inversely proportional. You all know. So whenever there is bradycardia, whenever there is hypotension, there is tachycardia. So that is a rule. So which among the following law states this? This is Boyle's law, that is Murray's law, that is Charles law, or none of the above? I will go through next slide. Shall I go to next slide?
Okay, sir. Please, sir.
So total spinal. So this is a really emergency. So whenever this is like complications while giving epidural. So whenever you are giving epidural, you end up giving that epidural injection in this CSF. So this is a emergency. There is severe hypotension, bradycardia, difficulty in breathing, weakness in hand. Difficulty in breathing because intercostal muscles are paralyzed, and this one even diaphragm gets paralyzed if the level is too high. Then weakness in hand, patient is unable to lift his hands. So so whenever you are considering giving high spinal for specific procedures, like some people do this one cholecystomy under spinal anesthesia. For that cholecystomy, you have to give a drug a little higher. So what we can do, you can give less drug at a higher space, not higher than L23, but you can give at L23, and you can make it 5 to 10 degree head low for say 2 to 5 minutes. So during that period also, you have to see for the signs of hypotension. So during the total spinal, there is loss of consciousness in terminal stages. For this, early recognition and prompt treatment to prevent the morbidity and mortality. So that early recognition is must by securing airway, by intubation, 100% oxygen, mechanical ventilation. So you have to do mechanical ventilation till the action of the drug wear off. So suppose you are using bupivacaine, then you have to ventilate that patient for at least say 1 to 1.5 hours. So if the patient like starts taking at his own, then you can consider giving sedation to these patients. So what is the general postoperative care for spinal anesthesia? So after every procedure, then whenever you shift the patient to the recovery room or their ward and all, so they should be in head low position, or limb should be elevated at least for 6 hours. Previously, we used to keep the patient head low for 24 hours, but nowadays early mobilization is a rule. So like we tend to keep them head low only for 6 hours. Then IV fluid, at least say 100 to 120 ml per hour should be given for a day. So whenever even you are doing a daycare surgery under spinal, you should give at least 3 to 4 IV fluids during that say 12 hours period. Then catheterization is a must, as you know, because sacral segments are blocked, so that there is chances of retention of urine always there. So catheterization you should always do for spinal anesthesia. Then neurological complications like meningitis, arachnoiditis, transforminitis, these are all neurological complications. For that, strict aseptic precaution is must, because these are preventable complications. Then like as I mentioned, injection of inappropriate drug or chemicals in the CSF, because like there was a case reported in UK. UK, even spinal anesthesia was banned almost for 20 years, because they used to like store that ampoule in this one methyl. Accidentally, they have injected some drug chemical. They used to store that in some chemical, and that chemical that has gone inside the CSF, and that 4 patients, they get paralyzed during that OT day. So that was quite tragedy I think in 1970s in UK. So the spinal procedure was banned for almost 10 20 years in UK. Then permanent paralysis, that is also a complication because of anterior spinal artery syndrome. Because in old age patients, so prolonged hypotension you should avoid for this. Then post-dural punctural headache, whenever you are puncturing dura, there are chances of headache because of continuous leakage of CSF. It is theoretical, but when you use smaller bore needle, the chances of PDPH are very, very less. So with 26 gauge needle, what we give, chances of PDPH are hardly say 1 to 2%. Bevel of the needle should always be parallel to spine. That you know. So the dura, the spine, whenever you inject through the whenever you do the LEPI, your bevel of the needle should be parallel to the spine, because that spinal fibers, they are the dural fibers, they run parallel to the spine. Then pencil point needle, chances of PDPH are less with pencil point needle. Then so what is the treatment of PDPH? So treatment is very simple. It consists of, let's say, that PDPH always increases in head up position. So patient should be either in flat, or you should make them head low for say 24 hours, and you have to encourage them to drink plenty of fluids. And simple painkillers can help. Even like coffee and Coca-Cola also help. We here gives some Dexona and Sibelium, but in resistance cases. So if in my private practice, I have never seen a case of PDPH in say my 20 years of private practice and 3 years of my PG days. So in 23 years, I have not come across a single case of epidural blood patch. So I'm not well versed with that technique. But in resistance cases, so that if that headache is persistent for so many days, then you have to consider epidural blood patch. Again, while administering epidural blood patch, again you have to take aseptic precautions. Then little bit about spinal anesthesia and obstetric. So for us, private anesthesists, majority of cases we do our obstetric cases like cesareans. So for cesarean, there is special consideration, because why we prefer spinal anesthesia over general anesthesia? Because babies are more alert. There is no problem with the airways. There is less risk of aspiration. That's Mendelssohn syndrome, and mothers can be with the babies. But in this one obstetric cases, it is very difficult to perform. So that during that learning curve, always for the PGs and all, they should first give in simple cases, and then later on they should try on obstetric cases, because even PDPH chances are more in obstetric cases. As I mentioned earlier, preeclampsia is not contraindicated. You can give spinal anesthesia also in preeclampsia, but we usually prefer epidural anesthesia, because they have added advantage also. Then eclampsia is relative contraindication. Here we usually don't whenever BP is like diastolic BP is more than less than 110, we usually give anesthesia for eclampsia also. Then in obstetric patients, preloading should be more. So usually, if you give one fluid, it is not enough. So at least 1 liter of fluid should be given prior. Mm. Any problem? Any problem?
Yeah, please go ahead. Please go ahead.
Yeah. Then the obstetric patients need more preloading, as I mentioned. They need smaller volume of drug. So, like for say average Indian height, say like 5 feet height, less than 2 cc is enough, 1.8 to 2 cc. So 5.1, 5.2 usually give 2 cc, and more than 5.2 height we usually give 2.2 cc. So like usually 4.5 feet height, usually 1.5 cc of 0.5% bupivacaine is sufficient. And then positioning of the patient is the most important, because as you know, there is aortocaval compression in supine position and supine hypotension syndrome. So that like supine position is avoided in pregnancy. And like with this hypotension, again you are administrating spinal, so that will be added effect, so that lateral position is always preferred for giving spinal anesthesia in obstetric patients. But patients are more comfortable in sitting position, so you can consider sitting also, but never supine. Then nasal oxygen always should be given to any patient for spinal anesthesia, but especially should be given for obstetric, because for consideration of the babies. Then you should avoid methargine, because like sudden increasing in blood volume, so almost 300 cc blood volume suddenly injected, so that is quite detrimental for the patient. Then catheterization of the bladder is must. Then about epidural anesthesia, it is also central neuraxial block. It is versatile because it can be given as a single shot. It can be you can put a catheter, and it can be a prolonged. The use of it can be used for anesthesia as well as analgesia, and can be used for prolonged surgeries if catheter is in place. So that are added advantage of epidural, and you can use as an adjunct to general anesthesia. So indication and contraindication are same as like spinal anesthesia, because nowadays there is craze of epidural anesthesia for obstetric analgesia also. So patients are demanding here in cities like Belgaum also. So for epidural anesthesia, most important is epidural space that I mentioned earlier. It is a space above the dura, and it runs from the foramen magnum to sacral hiatus. It contains the nerve venous plexus as well as fatty tissue. And anterior and posterior nerve roots pass across this space. So whenever you inject the drug, you inject a large volume of drug, because that through dural sleeve, that should get absorbed in the nerve roots. So this is ligamentum flavum and dura. So while administering epidural space, your needle should be in between the ligamentum flavum and dura. That is a potential space. So prerequisite for the epidural anesthesia is same as spinal, like all the checklists what I mentioned. Then consent, counseling of the patient, and most importantly coagulation profile, because you are puncturing with the wide bore needle. So chances of epidural trauma to epidural vein is always more with epidural needle, because it is say 18 gauge or 18 gauge 16 gauge needle. So chances of epidural hematoma and epidural abscess you have to consider. So that's why coagulation profile is must before epidural. Then strict aseptic precaution is always must. Then preferably you should use disposable kit, but like in private you can't use it for each and every patient. So what we usually do for say non-affordable patients, we use the same needle, but we use this one disposable catheter. We never use the same catheter for different patients, but catheter can be used for disposable catheter can be used. Epidural needle, you know, that is 2 needle 16-18 gauge with blunt bevel and curved tip. There is Hubbard tip with attached wing. There is glass versus plastic syringe. Glass is always better, but now the disposable kit contains syringe itself. So that is low resistance syringe. So that can be used for loss of resistance technique. Catheter usually have multiple holes or single hole at the end. Any can be done. There is filter attached to the end. So that filter is must, because it prevents accidental this one like any particulate matter going in the space, going in the catheter is avoided by the filter, and that filter also act as a bacterial filter. So that filter should be attached whenever it is there. So technique, there are many techniques with loss of resistance. You can either use with saline, either you can use this one air, or even mixed technique is there when you can this one take a little air and little water, and mixed technique also you can use as a loss of resistance. Position, there is you can give in the supine, lateral, approach, midline, paramedian. So usually we in private we usually use midline, paramedian for special cases when midline approach is failed. So this is about little about to his needle. So that curved needle tip, that is most important, because it causes less trauma, and at a thickened tip, that resistance you can feel better with to his needle. So like I'll describe the midline approach in short. Usually we have to infiltrate with local anesthesia because the needle is big. Then with 18 kg disposable needle, you should make a small hole and then insert epidural needle through supraspinous ligament, directing little capillate, and advance it into interspinal ligament. At this point, you just remove the stellate and attach the syringe. So grip both the wings of the needle between the thumb and forefinger of the hand, and plunger gently press to see the bounce. Needle carefully advance with the dorsum of the hand resting against the back. The dorsum of the hand acts as a like guard, so it should be rest against the back. And then after every 1 to 2 millimeter press, you have to press the plunger after every 1 to 2 millimeter. Then you can feel the increasing resistance while passing through the ligamentum flavum, because ligamentum flavum is quite thick structure, and sometimes it is almost 1 centimeter. This one, so that after every 1 to 2 meter, you have to press the plunger and check. So at this point, air, this one, you can feel the increasing resistance while passing through the phlegm, and continue the procedure till there is distant click. So you can feel a sudden giveaway sensation. At this point, you can water air can easily be injected in the space. Then remove the syringe and place the catheter. There are markings on the catheter. This one, 1 centimeter, 2 centimeter, 10 centimeter, 15 and 20. So that loss of resistance to saline also can be used. In this technique, there will be continuous pressure on the plunger, and left hand acts as a brake. So what are the troubleshooting? There is bony resistance everywhere. If there is bony resistance, you have to flex more, change the position, or you can use different space. If you are unable to thread the catheter, then rotate the catheter. Use the catheter stabilizer, that is this one provided with every disposable kit. Then there is pain on insertion of catheter. Catheter is against, so whenever there is pain on insertion, your catheter is against the nerve root. Then it should be withdrawn a little, and then again you have to reinsert it. If there is blood in the catheter, you are in the epidural vein, so you have to withdraw a little. So here is one technique. You have to withdraw till 12 centimeter mark, because say you have to be in the you are in the space already. So only say 2 centimeter in the space, because that needle is 9 centimeter. That mark 8 centimeter needle plus that hub, total 9 centimeter. So at 12 centimeter mark, you should stop and then flush that with saline. Then again you have to aspirate. If there is no blood, then again reinsert. So that is the one technique you can go for. Then what are the factors affecting epidural? Site of injection, definitely, because it is segmental block. So site of injection is matter more here than the spinal. Thoracic epidural space, that space is small, so lower volume is required, while this one L12 space is big, so big volume is required. So dose is like 1 to 2 ml per segment. So you have to be very, very careful, because margin of safety is less here, because dose is 1 to 2 ml per segment. Suppose you block, you have to block 5 to 6 segment, you have to give either 5 to 10 cc of drug. So like better to give little dose in incremental doses. Then volume and concentration matters. High volume, low concentration. If you give high volume, low concentration, then more segments gets blocked, but less than sensory and motor block. But still there is hypotension, because sympathetic block appears first. So even if you give a small or high volume with less drug, still there is chances of hypotension. And then height, so with less height you have to give less volume. Weight doesn't matter much unless there is obesity. So whenever there is obesity, less volume of drug required, because there are epidural veins are engorged, so epidural space is reduced, so volume required is less. Then posture doesn't have much effect, but there is little effect. Like many practitioners, even myself also, like giving in sitting position, more dense block occurs in sacral segment as well as forelimb and all. Then vasoconstriction, they prolongs the action. So whenever you use xylocan with adrenaline, then action gets prolonged. Alkylation can be used for more dense block. So for alkylation, you can use the soda bicarb. So that is 8.4% soda bicarb. If you add that 0.5 ml to 10 cc, that usually we follow. For every 10 cc, we add 0.5 cc of soda bicarb. So that solution become alkaline, and that block will be dense and earlier block. So what are the physiological segments? As you all know, this is segmental nerve block. Sensory and autonomic nerve fibers are smaller diameter. That's why they get readily blocked first. Motor fibers are larger diameter, so they block late. So sympathetic block extend one to two segment higher than sensory. So this point should be considered because there is chances of hypotension always there. So what are the effects on CVS? There is vasodilation, there is hypovolemia, there is hypotension. Exacerbation of sympathetic block. Then high block till T. So whenever there is high block till T10, sympathetic supply to the heart also is interrupted, and there is bradycardia. Then perfusion to vital organs get affected. So it should be treated promptly with IV fluids as well as vasopressors. There is not much effect on respiratory system per se, but if you give high block, then intercostal muscles get paralyzed. So like there is diaphragmatic breathing, and patients become very uncomfortable under this epidural anesthesia. So you have to supplement them with oxygen, and you have to monitor carefully. And GIT, the gastrointestinal tract, there is because of sympathetic blockade, there is unopposed parasympathetic. So vagal sacral, there is vagal dominance, sacral dominance. So peristalsis is active, sphincters are relaxed. So this is ideal situation for surgeons because like sphincters are relaxed and bowels are contracted. Then surgical access is better. Then spleen is always enlarged. Endocrine system, nerve supply to adrenals sometimes get blocked in high block. So there is a reduction in release of catecholamines. So this point also should be considered. Genitourinary, as I mentioned, retention of urine, and with hypotension there is decreased GFR. So again, urine is less. So in short, about effect on cardiovascular physiology during pregnancy, as I mentioned, there is aortic cover compression in supine hypotension syndrome. So venous return is less, so cardiac output is less. So when we administer epidural anesthesia, there is again sympathetic blockade, and there is again chances of hypotension. So epidural anesthesia along with peripheral vasodilation and hypotension, this combination of all the above lead to severe hypotension causing profound effect on uteroplacental blood flow. So this point should be considered. So supine position should not be given to any parturient. So lateral position is preferred. Then prompt correction of hypotension and combination of IV fluids, leg elevation as I mentioned in the spinal anesthesia, lateral position, and vasopressor. Ephedrine, as I mentioned, is a drug of choice because it increases BP by increasing cardiac output. But in profound hypotension, whenever there is profound hypotension, pure vasoconstrictions can be used. So what is single shot versus catheter? In private practice, many practitioners they still prefer single shot because like you can save on catheter. But major disadvantage of single shot is duration of post-operative anesthesia is limited. You cannot top it up. There is more hypotension because whatever dose is there, you administer full dose at a time. So chances of high block is always there, and that's why chances of total spinal anesthesia and LA toxicity is more with single shot technique. So it is difficult to justify the use of single shot. Complications and side effects of epidural anesthesia, hypotension, always there, but it is less than subarachnoid block, but it is gradual and manageable. So whenever you give high epidural block, there is so give high doses, then nausea, hypotension, paresthesia of high thoracic cervical nerve roots. So that so whenever you give high epidural, these also signs should be monitored. Then intercostal muscles also get paralyzed, so there is difficulty in breathing because only diaphragm is the main muscle of respiration. So oxygenation should always be maintained. Sometimes intubation needed to secure the airway if there is accidental injection of epidural dose in spinal, that is total spinal. So LA toxicity. So whenever you give any epidural dose, that first test dose should be given. Usually in private we use 2% xylocaine with adrenaline, 2.5 cc. So with 2.5 cc, even if you give in the say in the CSF also, with 2.5 cc that level gets achieved. And addition of adrenaline, there is always tachycardia, and also that usually we give xylocaine with adrenaline, but test dose we never give. We should not give bupivacaine. Then vital signs should be monitored properly while giving epidural anesthesia, and it is whenever you give, aspirate before every dose. So every dose there are chances that epidural catheter gets migrated in the epidural space. So whenever you give any injection, you should aspirate before every dose. So whenever you give in the this one in the epidural vein, like then there is lightheadedness, confusion, conversion, so coma and cardiorespiratory arrest. So accidental, that is accidental injection. Then early recognition is must, and you should discontinue the injection whenever you recognize it early, and you should treat promptly by this one. CPR should be because there is conversion, chances of conversion are very high when you injected that dose in this intravascular injection, so that you may need sedatives, anticonvulsant, and CPR. So that's why backup is always necessary. So like whenever you give anesthesia, so you should see for
Rajesh.
Sir.
Had an excellent preparation and talk. Shall we conclude with a couple of slides, please?
Yeah.
Because there is a list of questions for you.
Yeah.
Okay. Sorry for interrupting.
Yeah. So this is last slide. Actually, epidural hematoma. Sometimes you puncture the epidural vein, and there is bleeding in the epidural space. They can compress the spinal cord. And epidural abscess. So whenever there is failure of block, the catheter is always in the area other than epidural space. There is an anatomic variation, septa. You should change the position at the soda backup. So that is all. Thank you for patient hearing.
Thank you, Rajesh. I know how much hard work you have kept for the slides and preparations, and really an excellent being a private practitioner. My heartfelt congratulations to you. There is a list of questions. Before that, just let me add few things from my side, because I'm also a private practitioner for the last 24 years and completed 10,000 cesarean sections.
Yes, sir.
And
really
besides this private practice, I presented all the state conferences, national conferences, SARC, AOA, and many workshops, including a gynecologist conference and pediatric conference also. Okay, right. Thank you very much. Before that, one thing is, for interscreen block is the one of the ideal one for the shoulder surgeries. You need not go for a GA. And the second thing is CTBT got a very limited value for our information. And the third thing is, you mentioned something that when for private practice, pre-anesthetic checkup is a little bit difficult and all these things. But when a private practitioner anesthesiologist going for a single nursing home regularly, then he should take an advantage of a regular visit of the patient one day prior. For all my, not for you, not for you, for the juniors. They should take an advantage. They should visit a patient one day prior, because patients who are getting already admitted, they can, if they can see a patient one day prior to the surgery, they can advise some investigations, they can advise their anesthesia, pre-anesthetic workup, and especially they can examine the back, airway, regular PSC. If there is something problem in the back and airway, they can prepare a mindset. Again, they can prepare well for the next day. Second thing is, we should train an OT and an assistant in our place. They can train in CPR, monitoring, drugs, and everything. So it will be very useful for us. And they should check for circuit and oxygen emergency drugs and all these things. And my simple suggestions for the juniors private practice is, don't be heroic in a primitive setup or a primitive surgeon or a major surgery going in a primitive setup. Never be. One should know, the anesthetist should know when to say no to the surgeon.
Exactly, sir.
That's it. And don't be overstretched in a private practice. See, In a private setup like medical colleges, something different. But a private practice, if you stretch too much, if you attend at a late night for a intestinal obstruction, you will have a problem and patient will be in trouble. And thank you very much. Coming to the questionnaires in the chat box, what is the incidence and the severity of hypotension in sitting versus lateral position? Do you want to add or let me add? Please add. Please add.
Yeah. Chance of hypotension always more in lateral position than sitting position. Sitting position, chances of hypotension is always less. This one in private practice. So, like what we give, usually we give all orthopedic cases in sitting position. But for cesarean section, sometimes the high block could not be achieved with sitting position because we have to give very, very less drug to the this one in obstetric anesthesia. So for that, we usually prefer lateral position in obstetrics.
Okay. The next thing is Dr. Guru sir had sent one question: 2 to 2.5 ml of hyperbaric bupivacaine for saddle block is not at all required. Do you prefer 1 ml of hyperbaric is enough for the lower limb surgeries and pure saddle block without sympathetic block? Do you want to add any comments on that?
Usually we give around 2 cc because sometimes surgery may get prolonged. Limb surgeries you can't, like orthopedic surgeries, even they take almost say 40-45 minutes for preparation. Before starting the procedure itself will take 45 minutes, and then surgery may last for say 1 to 1.5 hours. So all in all, it is 2.5 hours surgeries. So in my opinion, usually we don't follow 1 cc, 1.5 cc. Because whatever we give, there is like no hypotension at all. Like with the 2 cc drug for limb surgeries, 2.5 cc, there is no hypotension at all. So like you can try 1 cc. If you can achieve with 1 cc, it is better always. But in private practice, it is very difficult to again give GA for that cases.
Yeah, Dr. Gurjat sir, he want to add that 2 to 2.5 ml hyperbaric bupivacaine is not at all enough required.
I think Gurjat sir can comment on that. Sir.
Yeah, that's right. That's
no,
fine.
what I wanted to tell you is because saddle block is mainly we are going to block S234.
S234, yeah.
And saddle block is mainly required for perineal surgeries.
Yeah,
it is not for orthopedic surgeries. Orthopedic surgeries,
no,
definitely you go for 3 ml or 4 ml or even 2.5 ml.
Oh, yeah, 2.5.
Saddle block, the main concept of saddle block is to prevent, sympathetic block and hypotension.
Okay, yeah.
So as long as you are giving lesser volume and keep the patient in sitting posture at least
for
5 to 10 minutes.
Yeah, 5 to 10 minutes.
And you're using an hyperbaric drug. So it's going to block only the S234 and the patient will be very comfortable and it's going to have a prolonged duration of action also because the drug is getting concentrated into only
in sacral segment. In sacral segment.
And that way if you add fentanyl or better than fentanyl is clonidine, at least about 30 micrograms, the patient will also have a post-op analgesia.
Analgesia also, yeah.
I was commenting only for saddle block.
Okay, yeah.
It is not for orthopedic surgery. Saddle block, till now I have used only 1 ml. I have never used more than 1 ml. I teach every student of mine to go for only 1 ml because higher the volume you give, the higher number of segments will get
blocked.
Probably hypotension will be a problem.
Yeah. Yes,
sir, Gurjat sir, if you permit me, I will add one point at the last of these questions. Okay. The next question, Rajesh, this when we are using 25 gauge spinal needle, do you compare this failure rate with the 25 versus other gauge needles?
Failures. See, sometimes at 26, usually we give, I use 26 because 25 is little sharp needle. What I appreciate that 25 needle is sharper than 26. So if you have not tried 26, you should try 26 gauge needle. So that is very, very good needle. So if you are well versed with 23 needle, then even 26 gauge needle also give the same sensation. But 25 needle, what we are using here, they are not good, I think. But 26 gauge needle failure are like suppose the patient is uncooperative, then chances of that needle this one get bent and all is there, but not much because for this one obstetric cases that ligament is very soft, so there is no chance of this one bending. Only in uncooperative patients there are chances of failure, but
so the point
not as per se.
The point is here is there is no much difference between the 25-26 gauges Number one. Number two, there is no much difference in a senior practitioner. Is it
Yeah,
correct?
yeah,
Okay,
yeah,
fine.
yeah,
Next
definitely.
question is, keeping in mind of this chemical meningitis, do you prefer povidone or chlorhexidine for the PrEP?
So we use usually powder and iodine, but after that we like wash it that with spirit. We usually spray it with spirit. So whatever iodine is there on the back, it should properly be washed with spirit.
Yeah.
And then
Let me add one point, sir. I definitely respect your seniority and statement. Both the things, povidone, iodine, povidone as well as chlorhexidine, both are good, provided they should not enter into the intake. Number one. Number two, after preparation of chlorhexidine for 3 minutes is enough. After that, spirit is not at all required. This is for the sake of junior practitioners only, not for you. Because once you clean the spirit after pedidine, the time spanning of povidone on the skin will be reduced. So better to keep the povidone on the skin as far as possible, so that it could be completely antiseptic. So better not to use the spirit. And povidone is definitely better than the chlorhexidine. And there is one study, there is one paper from UK in 2004 that they have produced. They have reported chlorhexidine induced meningitis in obstetric patients. So the next question is, the Gupta sir had commented one thing: the total spinal is more common with a single shot epidural. I hope, do you agree with that?
Yeah, definitely.
So single shot, the better to avoid all single shot epidural.
Yeah,
nowadays,
better to avoid.
Single epidural catch we are getting almost 150 rupees. So cost, it is not at all a problem.
Yeah.
Then one point you added in your slide is for the PDPH, the role of amitriptyline and sibelium. There is not much evidence-based medicine of the amitriptyline and sibelium. I hope you will agree with me.
Yeah, but like results are better with DEXA, with combination of DEXA with sibelium. Always patient see. So whenever in private, US with say plenty of fluids and like simple analgesic, it will go. But patients are not happy unless and until you like give them something. Even surgeons are also not happy with simple analgesics and all, because every postoperative patients, they are receiving diclofenac, they are receiving fluids and all. So they want something more. On that something more with whatever DEXA and sibelium, they are working for us at least.
So Rajesh, besides scientific data, so you want to focus on the private practice?
No. It's not like that, sir. But results are better with this one, because sometimes it may mimic vertigo. So sibelium is basically a drug used for vertigo.
No, there is no scientific data suggesting amitriptyline or sibelium in the PDPH. But the bottom line to be taken, there are list of drugs. Okay, that's good, fine. The role of nasal oxygen supplementation in spinal anesthesia, there is no much evidence for the supplement of nasal oxygen. Gupta sir also added a comment on that, and same thing, BJ also, there is no difference in outcome in the nasal oxygen supplementation for obstetric patients versus no oxygen. Okay, that's good. For one question is interesting: can we repeat spinal if the time lapses for a surgery is going on? So Gurdat sir also commented that it's better to give a general. I hope do you agree with that?
Yeah.
Then I think second thing like that, if there is no chance of CSC for the practitioner. One question from Dr. Anil: during spinal procedure, I think it is a procedure, if the patient get a vasovagal reflux or severe bradycardia, so what do you do?
Atropine is this one drug of choice is the case, and then make the patient supine, leg raise, because it is a vasovagal and all. And like fluid should be given fast, vasopressor if required. You can give urgently oxygenation.
Yeah, okay, that's good. The last one is Dr. Gupta sir has commented one thing, that continuous spinal is preferable if the anesthesiologist doesn't prefer for CSC, combined spinal epidural. I don't think continuous spinal is much advantage in a private practitioner who is running here and there. There are many limitations for continuous spinal. Better that go for an epidural CSC than the continuous spinal. There are many limitations. I hope Gurdas sir will agree with me. If you permit me, I will add only one point. For a LV dysfunction, high risk cardiac patients, amputation below knee, and diabetic foot. For diabetic foot especially, I usually give 0.5 ml in the right lateral position only. Only lateral, only 5 ml. I have done hundreds of cases. Hemodynamically very stable, very stable. Or BK amputation also have given 0.7 ml of bupivacaine with fentanyl. So I believe that Guru sir will accept this one also. No?
No, that is called as a selective spinal.
Yeah.
Unilateral.
Yeah, selective spinal is definitely it's more preferable whenever you think that the patient is hemodynamically unstable, and you want to see that majority of the segments are blocked on the dependent side and less number of segments are blocked on the non-dependent side. But the overall sympathetic blockade will be less, and so chance of hypotension will be less. But 0.5 ml or 0.7 ml may be too less for selective spinal also. Because usually for selective spinal, ideal would be about 1.5 ml.
Yeah, usually we give 1.2.
1.5 ml, keep the patient in that position only for about 10 minutes. And when injecting the drug, you have to inject very slowly so that you don't create turbulence there. If you create turbulence, so that the drug will go up also, and then non-dependent side also will be blocked. And preferably use a pencil-tipped, spinal needle. Because the most of the drug will go down with a pencil point tip of needle because the turbulence is much less. And one more thing to make it more selective is don't bring the patient to the knee joints and the hip joints straight. Keep the patient in that lateral position with the knee joints and hip joints flexed only. Because we had done a study, myself and Dr. Kulkarni, so wherein we had just compared these two positions, immediately bringing the patient's knee joint and hip joint straight, keeping the patient in the lateral position only, and in some of the patients, keeping them in the flexed position. So we found that the flex position had more selectivity than when you immediately bring the patient to the hip and the knee joints are straightened. So that is another thing which you can keep in your mind, especially as a private practitioner. Keep them in the flex position only, and keep the the nerves there taut. So if the nerves are not floating so much, and when you flex, they become taut, especially the cauda equina nerves. So they are the ones which we want to block. So if you just immediately relax the joints, the the nerves becomes less taut and they move up.
Yeah.
And also they may fall down also. That can produce actually both the sides get involved. So that is one thing you can always remember about.
Thank you very much, sir. Thank you very much. There is one more question in this chat box. The tachycardia after the spinal. Rajesh, please comment on that.
Yeah, usually there is tachycardia after spinal because of hypotension. So that Murray's law. Whenever there is hypotension, there is tachycardia. But sometimes, if the hypotension is severe, then there is stretch receptors in the heart because of peripheral pulling and all. So Benbury reflex takes over, and there is severe bradycardia. So that has to be taken care of.
Excellent,
Venugopal sir, there are two more questions in the YouTube.
Yeah, please.
Yeah, one is should adjuvants be administered separately or mixed with the local anesthetic? By Dr. Manjula.
Okay.
We usually add here clonidine. So usually we mix the clonidine in this one like bupivacaine.
How much clonidine do you add?
30 microgram, 30 to 50.
Okay.
Yeah.
Okay.
The
question is, do you mix it prior to that or not? That is the question from the YouTube. Is it Sri Ganesh? Is it okay?
Yes. Is it to be administered separately or mixed with the solution, local anesthetic solution?
Yeah. So the Sri Ganesh, I have compared a study of 50 mics of clonidine versus 75 mics in lower abdominal surgeries and presented in the state conference. The 75 mics is good, but you have to monitor very closely for bradycardia and severe hypotension for many hours of that. Okay, right. Thank you. And the second question, please.
Yeah, one more question is from the same YouTube. Is eclampsia an absolute contraindication for spinal anesthesia?
Do you want to add, Rajesh, or shall we comment?
Actually, eclampsia is, sir, as I mentioned earlier, also pre-eclampsia usually like spinal can be given. In eclampsia, we are preferring epidural, but spinal also many people they give if BP is normal. If BP is say like less than say 110 diastolic, still you can give spinal, but you have to judge it against general anesthesia. So that is personal choice. That is not an absolute contraindication per se.
Yeah, that's excellent. I will add one point. There is no absolute contraindication for eclampsia. If the senior anesthetists can do a subarachnoid block, provided you should check the coagulation profile prior to the subarachnoid block, because there are a lot of chances of altering the coagulation profile. If there is everything, he can go ahead for the eclampsia. It was already a paper statement in the AOA last year conference. That's good, fine. Rajesh?
But Dr. Venugopal, what is very important in eclamptic patients is the sensorium of the patient is very, very important. If the patient is unconscious, there is no chance of you going for epidural or spinal.
Yes.
Yeah, definitely.
It's always better to go
Point
for
taken.
GA.
Thank you.
That is one
Fine,
thing.
Fine.
And the second thing is, many of the textbooks say that at least, the patient should have had only one episode of convulsions. If the patient has had more number of convulsions, it is always better to go for GA rather than
Point
spinal or
taken,
epidural.
Point taken.
And the third thing is, last episode of the fit should be at least 3 to 4 hours. Interval should be there.
Okay, sir.
So, and the patient is fully conscious and there are no other contraindications for spinal or epidural, definitely you can go for that.
Point taken,
Agree,
sir.
Agree.
Guru is always Guru, sir. Yeah, point taken. Right. Thank you.
I think we will take on last 1 or 2 questions are there. Venugopal sir, you want to take that?
Yeah,
one
please.
Question.
Yeah.
How to manage partial or patchy spinal with your experience?
Partial or patchy. See, the one thing is I want to comment is, if it is adequate for the surgery, at least 75% we can proceed it by supplementing with opioids. If it is not up to that, it is better to either go for a GA or you could choose for some other technique, that depending upon the surgery. And keep it in mind about the surgeon. If the surgeon, it takes more time and then it's better to give for a GA. Thank you.
So what about repeat spinal?
Sir, I personally don't prefer for a repeat spinal, sir. Because by doing that, you are inviting many complications as per practice.
So there are two things, Dr. Venugopal, there. If it is total failure, the drug has not reached the CSF at all.
Yes.
Then definitely you can go for a repeat spinal. Many of us have used the repeat spinals. And suppose if it is partial block or a patchy block, as you said that it is very dangerous to repeat. Because we don't know how much drug is already there inside the CSF and you are adding some more drug. So it can even produce a total spinal, especially in cesarean sections.
Yes, sir.
So you have to be extremely careful. So if it is a total failure, I think you can still go for a second spinal, repeat spinal.
So patient, sir, I like to add one more point. So patient, if he is unable to lift the legs, then the spinal should not be repeated. Yes, sir.
Right.
So if the level is not adequate, but if she is not able to lift the legs, then this should not be repeated with spinal. Then whatever Venugopal sir has suggested, you have to add some opiates and this one or GA or whatever it is, but it should not be repeated.
Yes, sir. Fine.
I think our Vice President, Dr. Shivkumar Kumbar, wants to ask a question. Kumbar sir, please go ahead. And that will be the last question. I think we are already 9 now.
Dr. Gurdas sir.
Sir, Heli sir.
Sir, have you seen total spinal in your practice last 30-35 years?
Oh, sure. Total spinal many times.
Guru sir experienced it.
Yes, sir.
I have seen one case in post-radiation.
But none of the patients have had any problems because immediately it has been, because continuous monitoring was there, immediately recognized and managed. I've seen one total spinal with 1.5 ml of lidocaine 5% in a morbidly obese patient. Just 1.5 ml I had given for hysterectomy of 5% lidocaine with adrenaline. We used to rinse the syringe with adrenaline and we used to give.
Yes.
It was long back, almost about 30 years back. And suddenly, the blood was dark and I lost the pulse. and the patient was arrested. So I knew that there is something wrong. Immediately I could intubate, started ventilating. I used to fix 5 ml of 6 milligram per ml of mefentin. I just pushed that, atropine I pushed. So pulse got the pulse, and then, started ventilating. The patient did not breathe for 1.5 to 2 hours.
Okay.
And only after 2 hours, she started breathing, and she was fully awake afterwards. And it took almost 2.5 hours for her to completely become awake and could manage her airway and all. Then only I could take out the tube. So you cannot even imagine that 1.5 ml in morbidly obese patients can produce a total spinal. So you have to be extremely careful. You have to really monitor the patient after spinal or epidural. That is
Yes,
one
sir.
thing. Monitoring first 15 minutes, most important thing.
Most important, sir.
Last 10 years, there is no reported this thing, total spinal, in any of the journals.
Yeah, Vijayanand, probably the monitoring aspect was so much of improved for the last 10 years. Monitoring, multi-para monitors.
Now, one more thing, you were talking about the total spinal. After an epidural catheter was placed by one of our PGs, so he gave the test dose. So the test dose did not produce any problems. Actually, I'm not talking about the total spinal, what other complication had. So afterwards, he gave the regular dose of ropiocane. Ropiocane had just come then. So he wanted to try ropiocane. He gave about 10 ml of ropiocane. Immediately, the patient started having convulsions. So afterwards, immediately we managed by intubating the patient, and there was not much of a problem. There was slight bradycardia because ropiocane. It was intravascular placement of the catheter. Afterwards, when we aspirated, there was blood. So why the test dose was not conclusive was the patient was on a beta blocker. When a patient is on a beta blocker, even when you give adrenaline, so adrenaline will not produce any increase in heart rate. So that was the problem where our postgraduate did not recognize intravascular placement of the catheter. Fortunate for him, he had given ropiocane and not bupivacaine.
Gurdat sir, my small thing is ropivacaine 10 ml, does it produce any local and systemic toxicity?
Yeah, definitely.
Because, but it was not. But in this situation, it was not there.
No, there was mild hypotension and bradycardia, which we could manage.
No,
because,
no arrhythmias.
Cardiotoxicity of bupivacaine is many times can be irreversible.
Yes.
Though we use all these lipid emulsion and all those things.
Yes.
Many times it can be fatal also. So with ropiocane and levobupivacaine, because the cardiotoxicity is minimal, so we don't have much problem. That is why ropiocane and bupivacaine, levobupivacaine are also becoming popular.
For that same reason also, for all blocks, I will give only ropivacaine, sir. For the same single reason. No bupivacaine.
So, any comments from Param sir? He's another second moderator. Param sir, you want to add anything?
Sir is there, but he has to unmute.
Okay. The Shivkumar Kambar sir, our Vice President, had raised his hand. I'm not sure if he's still around.
He's there.
Kumbar sir, can you unmute and ask your question? Or comment? Yeah, please go ahead. Unmute and ask. Kumbar sir, unmute and ask.
Dr. Shivkumar, unmute.
We can see you raising your hand, but you are not speaking or you are not audible. I think he has some audio issue.
Net problem.
Yeah, Shivkumar.
No, I think.
Yeah, I did. Okay, can you hear me now?
Yeah, please go ahead.
Again, last.
Oh, probably internet problem.
Okay, Dr. Sunil, yours will be the last question.
Yeah, can you hear me now?
Yes, sir. Yeah, Shivkumar sir, go ahead.
Yeah, see, I have a small micro speakers. The choice of anesthesia, let it be the choice of anesthetist, okay? Not surgeon. Okay, if the choice of anesthesia is the choice of a surgeon, probably if something goes wrong, anesthesia will not escape in this. Can you hear me now?
Yes, sir. Your network is poor. You can off your video and ask only audio. Yeah.
Okay. See
no, sir.
Choice of anesthesia, let me be the surgeon.
Yeah, I think we understood the concept. I think all of us choice of
yes.
The other one, the other one is, even if the patient, I do agree with the choice of anesthesia by the patient only to a certain extent. But if the patient is insisting for that, again, it's not the choice of a patient, it's the choice of anesthesiologist only, legally.
Okay, sir. Okay.
Yeah. Legally,
Thank you, sir.
legally, the choice of anesthesia, not the patient or the surgeon. Yeah.
Okay. Sunil, last question, and then
Sir, sir,
please go ahead.
I have used both hyperbaric lidocaine and hyperbaric bupivacaine. My observation is that with the advent of hyperbaric bupivacaine, the extent of total spinal and high spinal is very less, sir. Is it true, sir?
Gurudat sir, anyone can take that. Venugopal sir.
So
what is the question?
Sir, I have used both hyperbaric lidocaine and hyperbaric bupivacaine, sir. My observation is with the advent of hyperbaric bupivacaine, the incidence and severity of total spinal is far less compared to hyperbaric lidocaine, sir.
No, but it all depends on the volume you inject and accidental injection when you are giving an epidural into the intrathecal space. So can produce whether it is lidocaine or bupivacaine. I don't think there will be any difference between lidocaine and bupivacaine as far as the total spinal. But if it occurs with bupivacaine, it is a prolonged one. With lidocaine, may not be so much prolonged.
Means whatever doses we are using for cesarean, both lidocaine and bupivacaine, but my observation is bupivacaine has very few episodes of total spinal as compared to lidocaine, sir.
No, you are talking about accidental epidurals or with spinal only?
No, sir, with spinal, sir. Spinal.
With spinal, it is very, very minimal. But, with spinal, it can occur, total spinal can occur for if a patient has been on labor analgesia for a long time. For example, now 5-6 hours of labor analgesia with epidural low dose bupivacaine, and suddenly the patient has been brought for a cesarean section. If you give a spinal, because epidural volume expansion has occurred, the chances of total spinal can occur. You have to be extremely careful about the dose of spinal anesthesia in such situations. And nowhere guidelines are not there how much to give, but you have to be cautious because even the small dose of 1.5 ml can produce total spinal in such situations, even with bupivacaine. So you have to be extremely careful, especially after labor analgesia.
Thank you, sir. Thank you, sir. Param sir, you are there? You want to make?
Please,
sir. Please, sir.
This is about?
No, in general, you want to give any comment as a moderator for this session, no? Or ask any question?
I think most of these discussions have been already done.
Okay,
I don't think there is anything for me to add now.
Fine, sir. Thank you, sir. I think I thank both the speakers, Dr. Rajesh Mane and Dr. Rajesh Latkar, for excellent presentation. Thank Param sir and Venugopal sir for moderating this session. Excellent interactive discussion, good questions. Gupta sir has stepped in and answered most of the questions. Thank you, sir. I request our president, Vijayanand sir, if he's around.
Yeah.
Concluding remarks, and then we'll close.
Before that.
Yeah, please, sir.
Sri Ganesh, thank you very much for giving an opportunity and an excellent interaction. Thank you very much. ISA Karnataka, great going. Congratulations. Thank you.
Sir. Thank you, sir. Yes, sir. Vijayanand, sir.
Yeah, thank you. All the speakers, Dr. Rajesh Mane and Dr. Rajesh Latkar. I thank Parmeshwar sir for joining, giving valuable opinion, and Dr. Gurudat sir for wonderful advisors and related expertise in the field. I thank all the audience for joining this monthly academic of Karnataka. Thank you.
Thank you, sir. And I think 10 minutes past 9. It's a long session. Thank you for your patience. All the.
Ganesh.
Yes, sir.
Ganesh.
Yeah, please go ahead, sir.
Yeah, on behalf of ISA Bangalore City, I want to thank ISA Karnataka for giving us the opportunity to present in this monthly education online of. Thank you again.
Thank you, sir. Thank you very much, sir, Mane sir. Thank you, Latkar sir. Thank you, Venugopal sir. Thank you, Param sir. I also thank the entire office bearers of ISA Karnataka for actively supporting our programs, and all the participants, postgraduates as well as practitioners, who are the stakeholders, who are the beneficiaries of such programs. Thank you once again, everyone. I also take this opportunity to thank Shilpa from A1 Logics for the technical support. Thank you, everyone, and good night. And there will not be any monthly session for December, as we have our state conference on 12th and 13th. So our next monthly session will be in January. Please do join us for our conference as well as monthly sessions. Thank you once again, and good night.